this is the session in which today we were in the session of the neuroanatomy, where all the important aspect was covered for the neuroanatomy, and as much as I was able to complete it, but today the maximum I will try to cover entire head and neck in this series and all the important topics, which is actually very important for you to know in the head and neck series. So let me start with the session. I just want to check with the students. So exactly, I want everybody to know about the things which will be covered in the head and neck series, and which is very, very important. Actually, one of the part of the head and neck series, that was of cranial foramina. Few topics are overlapping with the neuroanatomy and head and neck series, which we have already done. Okay. So if I talk about the important aspects to be covered up, it's important that we should be so yes, the thing is that the all important aspect will be definitely covered, so please don't worry about it. And the important things to be covered in this topic is, we will start with the scalp, then we will go with the important structures of the face, then we will go with all the triangles of head and neck. So actually what happens, why the triangles are very important? When I am talking about the triangles of head and neck, it means that you have all the structures in the anterior triangle, the sub triangles of the anterior triangle. We have got carotid, we have got digastric, we have got the submental, we have got the muscular triangle, we have got the subclavian triangle, we have got the occipital triangle, we have got the scaleno-vertebral triangle, we have got suboccipital triangle. Actually, many triangles are there, and all the important aspects of the triangles should be covered, because it's entirely very important. Yes, good morning everyone. Other than that, you should have an idea of glands of head and neck. Like you should be knowing about the parotid gland, you should be knowing about the submandibular gland, you should be knowing about the thyroid gland. Other than that, I will also cover pharynx, larynx. Okay, these are the important aspects to be covered up. So exactly, many things has a deep cervical fascia. So actually all these will be covered up along with the MCQs, which is very necessary to solve. Few MCQs, because entirely a MCQ session can be taken afterwards also. Other than that, I will also cover the tongue. Tongue is a very important topic if you are targeting the FMG exam or in the NEET PG exam. Tongue is very important topic. So we will cover up the tongue, we will cover up the orbit, the extraocular muscles. So actually today I have taken too many topics. All the vessels, important vessels and branches of the arteries will also be covered up. So let's start with this. So the first topic of today's session is layers of scalp. Okay. So as in the previous session also, when I started with the, actually my, how I start with the topic is like, for example, if I'm going with the neuroanatomy, I will open up the skull cap and go inside in the brain and the covering. Same way, when I start with the head and neck, I would like to start with the scalp. So you have to know the scalp layers as you proceed from superficial to deep, as you proceed from superficial to deep. So actually here we have got the first layer which I am talking is the skin. So the layers can be spelled by the word scalp, the spelling of the word scalp. So here S for the skin, C for the connective tissue, A for the aponeurotic layer, L for the loose connective tissue, and P for the pericranium. So we have got scalp, the 5 layers, and we have got all the structures in the same proportion as you proceed from superficial to deep. Skin, the connective tissue layer, which is dense, the aponeurotic layer, which is the aponeurotic layer for the two muscle bellies, that is the frontal and occipital muscle bellies. We have got loose connective tissue, and we have got the pericranium. So all these structures, as you proceed from outside to inside, is constituting the scalp layer. The epicranial aponeurosis, the loose areolar tissue, the pericranium. So all these are the layers. So actually when you see the skin, this is the skin, and in the skin what you can see, the hair follicles has been shown, the glands associated, the sebaceous gland and all. Then we have got the subcutaneous tissue which is adherent to it. This layer of the cutaneous tissue, the connective tissue layer will be dense. This is the aponeurotic layer which is containing two muscle bellies, and we have got the loose connective tissue which is also called as the dangerous layer of the scalp. I will tell you the reason why it is called as the dangerous layer of the scalp. And the innermost layer will be the P for the pericranium. So these are the layers of the scalp as you proceed from outer aspect to the inner aspect. Now I would also like to show you another image which will help you to understand these concepts. So we have got the skin, we have got the subcutaneous tissue, the musculoaponeurotic layer, and the loose areolar tissue, and the pericranium. All these layers are arranged in the same way, and we have to know the important structures residing in this. Now, one of the few points which I want you to tell, actually you can get confused that there are two connective tissue layer. One is the second layer, that is the connective tissue layer, that is dense, and the fourth layer is the loose connective tissue layer. The fourth layer, that is the loose connective tissue layer. If I talk about the fourth layer, it is highly important. Why? I will tell you. The reason why it is important is, actually, the reason why it is important is because it contains emissary vein. What does it contains? Emissary vein. The fourth layer is containing emissary vein, and this is forming a connection with the veins of the scalp on the outer aspect with the veins lying inside, that is dural venous sinuses. What does that mean? That means the infection from the outer aspect of the skull can be transmitted inside and can be leading to the infection of the dural venous sinuses. So that is highly important for you to note down. So done with this. Now we'll talk about the aponeurotic layer. The third layer is the aponeurotic layer. Let me slightly enlarge it. So when I enlarge it, you can see there is a frontalis muscle. As you can see here, this is the frontalis muscle belly. So there is a frontalis muscle belly on the anterior aspect, and there is an occipitalis muscle belly on the posterior aspect. So actually this is very important that you should know about both of these. Why? Because if I talk about the frontalis muscle, it is not having any bony attachment. So these two bellies, here is the frontalis bellies, and it is not having a bony attachment. It is merging. Actually what happens, if I talk about the frontalis muscle belly, it is merging with the skin. So exactly, it is actually merging. So it is inserting, it is merging with the epicranial aponeurosis, and it is merging with the tissues over the eyebrows and the root of the nose and the eyebrows and all structures. So actually it is not having a bony attachment. But when you now I also want you to show another muscle belly, that is posteriorly, that is called as occipital muscle belly. So when I am talking about the occipital muscle belly, what happens? It is actually having a bony attachment. It is arising from the lateral 2/3 part of the superior nuchal line. If you will see in the posterior aspect of the occipital bone, there are two lines which is diverging. Okay, in the skull, when you view the skull from the posterior aspect, the two lines which is diverging is superior nuchal line, and occipital muscle belly is attached to that superior nuchal line. The two side occipital belly and the frontal belly will fuse with each other, leading to the formation of epicranial aponeurosis. So the gap which is lying between the frontalis muscle belly and that of occipitalis muscle belly is fused with epicranial aponeurosis. Okay, so it is important for you to note down. And other than that, it's also important that these muscle bellies are getting innervation. So they are getting innervation from the branches of facial nerve. So I just write down here one important point which I want everybody to note down is the frontalis muscle bellies arises from the tissue over the eyebrows and root of nose, and it runs backward. Actually what happens, it runs backward and merges with, that of epicranial aponeurosis. The deeper fibers of frontalis muscle, so this was one important, the deeper fibers of frontalis muscle belly is actually longer, and it is actually merging with the muscles. It is merging with the muscles like procerus muscle, corrugator superciliary, and orbicularis oculi. So it merges with procerus muscle, corrugator superciliary, and that of orbicularis oculi. So actually these are the muscles. So we have got corrugator supercilii, orbicularis oculi. So actually these are the muscles around here in the nose, and also the muscles which is lying at the, so we have got these muscles here. So we have got orbicular, so actually these are merging with the muscles here. So exactly, that is highly important for you to note out. So in short, what I want everybody to understand is that if I am talking about an important aspect here, so if I'm talking about an important aspect here, I just want everybody to understand that these is very important. Why? I will tell you, because this is how it is not having any bony attachment. So this is entirely for the reason that this is not having any bony attachment. So so if I talk about occipitalis muscle, so in between I will check with the mobile. If you have got any doubt, you can ask in the chat box. So occipitalis muscle belly is actually attached to, if I talk about occipitalis muscle bellies, they arises from the lateral 2/3 of superior nuchal line and extend and merges with epicranial aponeurosis. So actually the gap is filled with the gap, that is epicranial aponeurosis, and this is having a bony attachment. Now the frontalis muscle belly, so I will actually, if I talk about the frontalis bellies, they are innervated by temporal branch of facial nerve, and the occipitalis bellies are innervated by posterior auricular branch of facial nerve. So in other words, you can say both of these are innervated by the motor branches of facial. What you can say, both of these muscles are innervated by the motor branches of facial. Now, I would also like to explain the nerve supply. Actually, scalp nerve supply is very important. So the nerve supply can be understood by seeing this image. So let me just check with the students also, are they are able to understand or not. If anything which you are not able to understand, you can just let me know. Okay. So yes, ma'am, yes, Vrishalis. Okay, thanks for the appreciation. So exactly, so I just want that you should see this image and you can understand the innervation which is lying on the scalp. So if I enlarge this image, you can see there are actually, whole of the scalp is having 8 nerves. Okay, how many nerves the scalp is having? The scalp is having 8 nerves. So just focus on this image. So it is having an overall of 8 nerves, and in that 10 nerves are there, 8 are the sensory and 2 are the motor. So to 2 motor already known, which is giving innervation to frontalis muscle belly and that of the occipitalis muscle belly. But if I talk about the other sensory branches, what you can see, the sensory branches are giving innervation to the scalp area anterior to that of the auricle and posterior to that of the auricle. So there are 4 sensory nerves which is giving innervation to the anterior part of the scalp, and there are other 4 sensory nerves which is giving innervation to the posterior part of the scalp. So exactly here we can here we can see this is the supratrochlear nerve. So I just want to highlight it. So just know the name of these nerves. So this is the supratrochlear and this is the supraorbital nerve. So actually supratrochlear, supraorbital nerves, these are the branch from the ophthalmic division of trigeminal nerve. And then we have got zygomatico-temporal. Zygomatico-temporal nerve is the, so if you want I can slightly enlarge it. Let me just see. Can you appreciate? Yeah. So we have got the supratrochlear, we have got auriculotemporal. So we have got these nerves. We have got these nerves. Yes, you are right. Actually, yes, medicine, you are right. So actually, supratrochlear, supraorbital are the branch of ophthalmic division of trigeminal nerve. Zygomatic temporal is the branch of maxillary division of trigeminal nerve, and auriculotemporal is the branch of mandibular division of trigeminal nerve. So that means these are the branches of trigeminal nerve. Okay, absolutely right, Shahil. And then we will come to the nerves which is lying posterior to the auricle. If I am talking of the posterior aspect, we have got following nerves. We have got great auricular nerve. I just want everybody to know the name of the nerve and also the root values, because in few of the questions being asked in the previous year of examination, they have directly asked about the root value of this nerve. So great auricular nerve is having the root value of C2 and C3. The lesser occipital is having the root value of C2, and that of greater occipital. The great occipital nerve is having C2, and third occipital, very easy to remember, it will be C3. Yes, so exactly you are right, Sahil. If we talk about great auricular, lesser occipital, greater occipital and third occipital, they are the branches of cervical plexus. So Sahil is absolutely right. So how many? So in overall, what you can say, there are 8 sensory nerves. There are 8 sensory nerves in the scalp, and there are 2 motor nerves. 2 motor nerves. So actually motor nerves has already been done, and we know that the frontalis muscle belly and occipitalis muscle belly is getting motor innervation. Is it okay? Is it okay, dear? So that all are getting innervations, and so let's talk about the next. So here also I just want to rub one important. Yeah. So here I want, this is another image where I want everybody to appreciate the arterial supply and the nerve supply. So let me slightly enlarge this image. So actually nerves has already been done. So there are 10 nerves and there are 5 arteries which is giving, there are 10 nerves and there are 5 arteries which is giving the arterial supply onto the scalp. So that is important for you to note down. So let's talk about the arterial supply. So in that case, what you can say, the name of that 5 arteries are supratrochlear, supraorbital, okay, supratrochlear, supraorbital, superficial temporal, posterior auricular artery, and that of occipital artery. So these are the 5 arteries. These are exactly the 5 arteries. Wait a minute. Yeah, these are exactly the 5 arteries which is giving arterial supply to the scalp. In this case, what I want everybody to understand, the supra, can anybody give me the answer? Supratrochlear and supraorbital arteries are the branches of which artery? Can anybody give me the answer? Supratrochlear, supraorbital arteries are the branches of which artery? So Sahil is telling it's internal carotid arteries. Sahil, you are absolutely right. Venkatesh is also telling, yeah, but I got a better answer, ophthalmic branch of internal carotid. This was what I was searching for. Yes. So these supratrochlear, supraorbital are the branch of ophthalmic artery, which is subsequently the branch of internal carotid artery. Same way, here superficial temporal is the terminal branch of external carotid artery. Posterior auricular and occipital are the posterior branch of external carotid artery. So you are absolutely right. So if you want, you can write this also. So I just want to enlarge this image, and I just want, we have already done the nerves part. So I just want everybody to concentrate on the arterial supply. So you can just write it. Yes, Sahil, you are absolutely right. I just want everybody to note down. Here, supratrochlear, supraorbital are the branch of ophthalmic artery, and ophthalmic artery is subsequently the branch of ICA, internal carotid artery. Superficial temporal is the branch of, superficial temporal is the terminal branch of ECA, external carotid artery. Posterior auricular is the posterior branch of ECA, that is external carotid artery. Occipital artery is posterior branch of ECA, that is external carotid artery. So you can see these are the branches, and you have to know the name of these arteries. Now I would also like to talk about the venous drainage, which is very important for you to understand. Actually this is an image which will help you to understand about the scalp and the facial vein drainage on the face. Why it is very important? Because already in the studies session we have completed cavernous sinus, and I just want everybody to pay attention to this, because cavernous sinus infection is quite common, leading to cavernous sinus thrombosis. So there are certain routes which is draining the infection from the dangerous triangular area of the face to that of cavernous sinus. So that route will be also known to you, but important veins which is draining the face and the scalp. So I just want to enlarge this image. So when I am enlarging it, here I want you to show. Okay, so you can see this is the supratrochlear and supraorbital veins. These are actually draining angular veins, and they are subsequently draining angular veins, and they are subsequently forming the facial vein. So what is this? This is the facial vein form. That is clear to you. Now I just want you to explain about the formation of retromandibular vein. So please focus on which vein? Retromandibular vein. So all of you pay attention to retromandibular vein. So this is the retromandibular vein. So when I am talking about retro, let me slightly enlarge it. Yeah, when I am talking about retromandibular vein, in this diagram itself, you can appreciate this is the retromandibular vein. This is formed by, what is the formation? So you can see it is formed by the joining of maxillary vein. So it is formed by the joining of maxillary vein and that of the superficial temporal vein. So this is superficial temporal vein and this is the maxillary vein. So these two veins, superficial temporal and maxillary vein, will join and lead to the formation of retromandibular vein. In short, we talk about retromandibular. If we talk about the retromandibular vein, RMV the word we use, and this is how it formed. Now after the formation of retromandibular vein, if you want slightly, yeah, after the formation of retromandibular vein, what happens? It divides into anterior and posterior division. So you can see this is the anterior division of retromandibular vein, which will join with the facial vein and lead to the formation of common facial vein. This will lead to the formation of common facial vein, and common facial vein is draining into which vein? It is draining into internal jugular vein. It is draining into internal jugular vein. Clear? Now we will see that there is a posterior division of retromandibular vein which will join with the posterior auricular vein. So this is the posterior auricular vein which joins with the posterior division of the retromandibular vein and leads to the formation of external jugular vein. So this is posterior division of retromandibular vein. Okay, so where were we? I will just come to that point. Yes. So we were here. So let me slightly enlarge it. Okay. So we were here. And in this case, you can see this is the posterior division of retromandibular vein. And as I told you, the posterior division of retromandibular vein, this is the posterior division of retromandibular vein, which is joining the posterior auricular vein. So this is posterior auricular vein and this is the retromandibular vein. Both of these will join and lead to the formation of external jugular vein. External jugular vein is draining into which vein? It drains into subclavian vein. So is it clear to you, everyone? Other important point which I want everybody to concentrate, if you have got any doubt, you can ask me. The facial vein will communicate with the deep facial vein as shown in the diagram, and the deep facial vein will communicate with pterygoid venous plexus and will drain infection to via emissary vein. It will drain infection to cavernous sinus. So this route is also important for you. Facial vein, as we have seen, the facial vein forms communication with deep facial vein. Deep facial vein form communication with pterygoid venous plexus. Pterygoid venous plexus via emissary vein drain infection into the cavernous sinus. So these are the important veins formed. If you want a quick important points can be also done. So if you wait a minute. Okay. Now see here. So I just want that everybody, if you want, I can read, I can just write important aspects of it. So quickly we can write it if you want, because few must can get confused. So one of the route of infection, please write down route of infection, of cavernous sinus thrombosis. So one of the route of infection of cavernous sinus thrombosis has been shown here, and in that case that route of infection is via facial vein communicate with deep facial vein. Deep facial vein communicate with pterygoid venous plexus. Pterygoid venous plexus communicate via emissary vein, and the infection is reaching to which structure? The infection is reaching to cavernous sinus and leading to the condition of cavernous sinus thrombosis which vessel lead to the infection in brain in inferior nose and upper border of the superior lip. Actually, inferior aspect of the nose and the upper area of the face, that is called, firstly, an earlier time it was called, Venkatesh, in earlier time we were telling this area into the dangerous area of the face. Now we take a whole triangular area of the face, which is the dangerous area, and via, there are two routes of infection. One is via superior ophthalmic vein, other is facial vein communicating with the deep facial vein. So it is via deep facial vein and facial vein the infection reaches to the pterygoid venous plexus. Ultimately via emissary vein it is transmitted to the cavernous sinus, leading to cavernous sinus thrombosis. Is it okay, Venkatesh? So this is the route which has to be explained. Now I also want everybody to understand surgical layer of the scalp. So that whole pathway I have written, you can go through it. Okay, Venkatesh. The other communication is also via superior ophthalmic vein. The infection can drain into the interior of cavernous sinus thrombosis. In the studies class, I already have explained it. If you have missed out, you can see that neuroanatomy session. Okay. Surgical, I have explained that in the cavernous sinus thrombosis, cavernous sinus session. So you can just see that. Now talking about the surgical layer of the scalp. So actually 3 layers of the scalp. There are 3 layers of the scalp. We have got the skin. So we have got the skin. We have got the connective tissue layer. Connective tissue layer. So actually this connective, if I talk about this connective tissue layer, this is actually dense. So this is the first layer, this is the second layer, and we have got a third layer, that is epicranial aponeurosis, which is connecting two muscle bellies, frontalis and that of the occipital. And these three layers together is called as surgical layer of scalp. Now the doubt which must be arising to you, why these three layers are called as surgical layer of the scalp. The reason is that the 3 layers of this is very difficult to separate. Okay, it's very difficult to separate these 3 layers, and together they are called as surgical layer of the scalp, or called as scalp proper. In earlier times, also there was a procedure of giving punishment to the accused person, and in that case they have removed, for punishing the punishment, they removed the 3 layers of the scalp, that is scalp proper, in case of punishment for the rape cases. Now the next is black eye. So actually whenever there is a direct blow or hit, if there is a direct blow or hit on the face, what happens? There is actually accumulation of fluid and blood in the area around the eye. This condition is called as black eye. And if you remember, I told you, yes, you are absolutely right, raccoon eyes. Yes, you are absolutely right. Actually, the reason I want you to explain, the reason is that the frontalis belly is not having any bony attachment. It's not having any bony attachment. It is just merging with the muscles like corrugator superciliary procerus and orbicularis oculi. So exactly the blood can penetrate. It cannot, it will be letting accumulated inside and around the eye. So this is the reason. And the reason is that the frontalis muscle belly is having no bony attachment. Frontal bellies has no bony attachment. Now, other condition which I want everybody. So, firstly, I want you to give few differentiating feature of the 2 condition, which is called as captive succedaneum and the other is called as cephal hematoma. So, I just want to enlarge it. There is one condition that is called as captive succedaneum, and the other condition is called as cephal hematoma. So, it's important to differentiate both of it. Actually, the most serious one is cephal hematoma. The most serious one will be cephal hematoma. Actually, cephal hematoma, in case of cephal hematoma, there is subperiosteal bleeding. Which bleeding? The reason of formation of cephal hematoma is subperiosteal bleeding, but the reason of formation of captive succedaneum is just the pressure, which is actually, this is very superficial accumulation of soft tissue being compressed when the baby's head during vaginal delivery, there is compression of the head part of the baby by the bony cervical canal and all. So exactly, it's the fetal head is compressed against the cervix during the labor, and in that case there can be compression of superficial veins, and it will be corrected in about 7 to 10 days. So it is sometimes in few hours only that that swelling is gone, and it does not increases in size, but the cephal hematoma increases in size. And the other important point is the swelling crosses the suture line. So the swelling is a generalized swelling. If I talk about the condition of caput succedaneum, there is a generalized swelling, but if you will see the cephal hematoma condition, there is a correct outline of the swelling, and so swelling does not crosses the suture line. In the case of cephal hematoma, the swelling, for example, most commonly the parietal region, and it will accumulate the parietal and will not be seen in the occipital region. So the marking and the swelling is demarcated by the suture line, but in case of caput succedaneum, it can cross the suture line. The complication is associated with cephal hematoma because it is caused due to subperiosteal hemorrhages, and it takes much more days and months to get resolved, and it can be complicated also. So I just want everybody to see the two condition. One is caput succedaneum. So you can see the baby is born. Can everybody appreciate? The baby is born, and in this condition of caput succedaneum, what you can appreciate? What you can appreciate, there is a generalized swelling. There is a generalized swelling, but why I am showing you this images, because it can come as an image based question. But when you are seeing cephal hematoma, you can see the swelling has got a definite size. The swelling is having a defined border. The swelling is having a defined border. Now, I would also like to show you an image. Here you can appreciate about the accumulations. So you can see the condition of caput succedaneum, the accumulation of fluid is just in the second layer, that is the connective tissue layer beneath the skin. Cephal hematoma, you can see the blood collection is there, and exactly it is just in between the epicranial and the periosteum layer. This is the epidural, and the subgaleal hematoma is the accumulation beneath the aponeurotic layer. So actually these all layers has been demarcated in the scalp and also shown you the accumulation of fluid and the so basically the difference which you have to know is the difference between caput succedaneum and cephal hematoma, which has already been enumerated. Now let's come to a very important topic, that is triangles of the neck. Triangles of neck is a very important topic, and many triangles are there, and I will cover entire triangles and many of the structures residing there. Okay, so can we start with the session, everyone? So we have got posterior triangle and we have got an anterior triangle. Okay, dear. So I just want everybody to firstly understand what is posterior triangle and what are the structures lying inside. How is the roof of posterior triangle formed? What is the structure which is forming the floor of posterior triangle? What are the structures residing in the posterior triangle? So I just want everybody to understand all these important features. So if you will see this image, I am just enlarging it. You can appreciate the posterior triangle. So the outline of posterior triangle is this. So I just want, this is the whole outline of the posterior triangle. Okay. So here what happens, the posterior triangle is defined by, so we have got a muscle which is lying anteriorly, we have got a muscle which is lying posteriorly. So I would like to use a brown color for it. And you can see this muscle is sternocleidomastoid muscle. Which muscle is this? This is the sternocleidomastoid muscle. So you can just write down this muscle is sternocleidomastoid muscle, which is lying in the anterior. So this is forming anterior border of the posterior triangle, and the muscle which is lying posteriorly is the trapezius muscle. This muscle is the T for trapezius muscle. We will mention T for the trapezius muscle. So here this is the T for the trapezius muscle. So exactly, if I have to define the boundaries of the posterior triangle, how I am going to define it? The sternocleidomastoid muscle is forming the anterior border of posterior triangle. The trapezius muscle is forming the posterior border of the posterior triangle, and this is the apex. So apex is the area where the sternocleidomastoid and trapezius muscle is meeting. Actually, that is the area of superior nuchal line of the occipital bone, and the base is formed by this. What is this? This structure is forming the base, and this is the middle 1/3 of the clavicle. So this is formed by the 1/3. This is formed by 1/3 middle part of clavicle. Middle 1/3 middle part of clavicle. This is formed by 1/3 of the middle part of clavicle. So done. So you can clearly see this. Okay. Now here so we can see the boundary of the entire posterior triangle, and also I want you to define the belly. So here in this diagram you can see this is the omohyoid muscle belly. So actually there is inferior belly of omohyoid, the triangular space which is lying above the inferior belly of omohyoid, that triangular space is the occipital triangle, and the triangular space which is lying below the inferior belly of omohyoid, that is called as the subclavian triangle. So it is important that you should define the boundaries of occipital triangle. You should be knowing where is the subclavian triangle, and you have to know the contents, the roof and the floor. So everybody, are you clear with the boundaries? Are you clear with the boundaries of posterior triangle? Should I move further? Okay, done. Okay, everyone. So done, everyone. Let's write the boundaries. So I just want everybody to, this is the roof, this is the roof, this is the floor. So I just want everybody to first write the boundaries. So let's start with the boundaries. So all of you, please write on the heading boundaries of posterior triangle. Boundaries of posterior triangle of neck. Boundaries of posterior triangle of neck. Boundaries of posterior triangle of neck. So the boundaries are, please write down. What is this? Boundaries of posterior triangle of neck. And the boundaries are, so anteriorly it is bounded by posterior border of sternocleidomastoid muscle. Posteriorly it is bounded by anterior border of trapezius muscle. Inferiorly or base, inferior or base is formed by superior aspect of middle 1/3 of clavicle. Okay, apex, if I talk about superior aspect or apex, apex is formed by meeting point of sternocleidomastoid and trapezius muscle at the superior nuchal line of occipital bone, at the superior nuchal line of occipital bone. Okay, so done. So here we have done with the boundaries. So what we have done with the boundaries. So everyone, is it okay? We have done with the boundaries. Now I want everyone to concentrate for the so we have done with the boundaries. Now let's talk about the roof firstly. So as I want you to tell about the roof, so if we are talking about the roof structures, the roof is formed by investing layer of deep cervical fascia. So we know that whole of the neck is surrounded by a fascia. The name of that fascia is deep cervical fascia. So in this categorization, the roof of posterior triangle is formed by investing layer of deep cervical fascia, and this is stretching between the sternocleidomastoid and trapezius muscle. And actually the investing layer of deep cervical fascia will be overlapped by the superficial fascia and the skin. So roof is, and also roof, here we can see this is the muscle. This is the muscle which is lying in the superficial fascia of the roof, that is platysma muscle. Which muscle is this? Platysma muscle. So exactly roof of posterior triangle is formed by investing layer of deep cervical fascia. It is formed by investing layer of deep cervical fascia. It is formed by investing layer of deep cervical fascia, and which is actually overlapped by the superficial fascia is covering the roof. So you just can write this also. The superficial fascia is covering the roof, and it will contain few important structures. It will have the it will have external, it will have a muscle, that is platysma muscle, external jugular vein, and cutaneous nerve. So actually I just want everybody, so all of you please concentrate on this cadaveric image. So this is a cadaveric image which I am sharing with you. And actually in this cadaveric image, what you have to understand, is the structures of the roof and what are the structures which is residing. So exactly I just want to use black color. So this is sternocleidomastoid muscle. Which muscle is this? This is the sternocleidomastoid muscle. This is sternocleidomastoid muscle. This is sternocleidomastoid muscle. Okay. Posteriorly, we have got, this is the part of the muscle which you are seeing. This is the part of the muscle which you are seeing is this. So this is the joining of both the muscles. Okay. And this part which you are seeing is A for the apex, and this is B for the base, and this muscle which you are seeing here is the trapezius muscle. This is T for the trapezius muscle. This is T for trapezius muscle. So done. So in short, we have done with the boundaries. So I feel that you can understand the boundaries of the posterior triangle of the neck. Now the next point is to know the roof structures. What all the structures are residing in the roof? So that is important for you have to understand that. So for that, I just want everybody. So I just want everybody to concentrate. So exactly here we have got important structures. So nerves are there. So exactly we are having important nerves. So this is the nerve which you are seeing. This is the nerve which you are seeing. This is the nerve which you are seeing, and these are the nerves which you are seeing. So actually the nerve which is shown lower down going towards the clavicle. So I just want to use yeah. So this will be this will be the supraclavicular nerves. This is supraclavicular nerves. Yes, these are the this is the cervical point, and the nerves are emerging out from these points. Yes, these are the cervical point or the posterior border of the sternocleidomastoid, and we have got so other than that, we have got many important nerves residing. We have got great auricular nerve, we have got transverse cervical nerve. So we have got transverse. So this nerve which you are seeing here will be the transverse cervical. So this is transverse cervical nerve. This is the supraclavicular nerve which already written. Yeah, this will be the great auricular and the lesser occipital nerve. So this is the lesser occipital, and this will be the great auricular nerve. So these are the nerves which is seen in the superficial fascia of the posterior triangle. And what about the vein? So the vein is, I'm just using blue color for the vein, and this vein which you are seeing is the external jugular vein. So the vein is also visible, and that is external jugular vein, which will be seen in the posterior triangle of the neck. So exactly these are the structures in the cadaveric image of the posterior triangle of the neck, which we have written, which have just seen. I would like to write the details of it also. So we'll talk about the details of it also. So please write on the heading roof of posterior triangle and the structures residing. Roof of posterior triangle of neck. Roof of posterior triangle of the neck. So if I talk about the roof of posterior triangle of the neck, we will know the details. So the roof of posterior triangle of the neck is having, it's formed by investing layer of deep cervical fascia, which I have already written, and the roof is overlapped by, so it is overlapped by superficial fascia. And this superficial fascia will contain, so if I talk about the superficial fascia, there are certain structures residing in the superficial fascia, and the superficial fascia will contain a muscle, that is platysma muscle. So can anybody tell me the muscles which is lying in the superficial fascia? Yes, you are absolutely right, Shahil. If I talk about the important structures in the superficial fascia, we have got external jugular vein, we have got the branches of the cervical plexus, we have got the platysma muscle. Here the platysma muscle is residing in the superficial fascia, and the muscles which is residing in the superficial fascia, a common term is used for these kind of the muscle, and what is it called as? It is called as a type of panniculus carnosus muscle. So platysma is there, we have got external jugular vein, we have got branches of cervical plexus, and here we have got 4 cutaneous nerves. So let's talk about that 4 nerves. The 4 cutaneous, so we have got 4 cutaneous branches of cervical plexus. We have got lesser occipital nerve, which is having the root value C2. We have got the greater auricular nerve, having the root value C2 and C3. We have got the transverse cervical nerve, having again the root value C2 and C3. We have got the supraclavicular nerve, which is called as C3 and C4. So actually all these are the branches of the cervical plexus. Done with this, all these are the branches from the cervical plexus. Now, so we have done with this. Now we will talk about the floor of posterior triangle. So it's important to know the floor of posterior triangle, and actually if we see the floor of posterior triangle, it is also overlapped by the layer. So it is overlapped by the other layer. Yes, Sahil, you are absolutely right that supraclavicular nerve is ultimately having, so Sahil is giving an extra information that is absolutely correct, that supraclavicular nerve is having lateral, medial and intermediate branches. And can you tell me among these branches, which is the branch which is piercing the clavicle bone? And that is the reason clavicle bone is an example of atypical long bone. Can anybody tell me? Sahil can give me the answer. Sahil is absolutely right that there are 3 branches. So he is absolutely right that there are 3 branches, and among this I just want to know which is the branch which is piercing the clavicle, and the name of that branch is intermediate branch of supraclavicular nerve. So only the clavicle is regarded as a atypical bone. Okay. Floor of posterior triangle is covered by pre-vertebral layer of deep cervical fascia. It is covered by pre-vertebral layer of deep cervical fascia, and we have to know the name of the floor muscle. We have to also know the important structure which is plastered on the pre-vertebral layer of deep cervical fascia. It's also important that you should know the pre-vertebral layer of deep cervical fascia will continue in the axilla and will lead to the formation of axillary fascia. So you can just write floor of posterior triangle is formed by pre-vertebral fascia. That is the part of deep cervical fascia. Pre-vertebral fascia is the part of deep cervical fascia, and it's important to know that all the muscles which is forming the floor. So we have got many muscles, and few important muscles which is very important for you to know is semi spinalis capitis, we have got splenius capitis, we have got levator scapulae, we have got scalenus medius, and we have got first digitations of sometimes we have got first digitations of serratus anterior muscle. So all these muscles which I have written is the muscle forming the floor of posterior triangle. All these muscles are forming the floor of posterior triangle, and the floor of posterior triangle is covered by prevertebral layer of deep cervical fascia. Now so here we can see the boundaries, and we can see the muscles also. We can see the apex, base, and the anterior posterior boundary of the posterior triangle. And here we can see the muscles forming the floor of posterior triangle, which I have already written. Semispinalis capitis has been shown. Splenial capitis has been shown. The levator scapulae, the scalenus medius muscle has been shown. The next important thing is to know the content of posterior triangle. So if I want to pay attention to this point, the content of posterior triangle can be memorized by knowing the content which is lying in the occipital triangle, and by knowing the content which is lying in the subclavian triangle. Actually, there is a muscle belly which is called as inferior belly of omohyoid muscle, which is overall dividing the posterior triangle into two parts. The area which is lying above the inferior belly of omohyoid is the occipital triangle, and the area which is lying below the inferior belly of omohyoid is the subclavian triangle. And individually you have to know the contents in each of these triangular spaces, in the occipital triangle and in that of the subclavian triangular spaces. You have to know the content. So exactly we will talk about the contents of these individual triangle. So firstly I will write the content, but I just want everyone to see this image. Actually in this image the occipital triangle has been designated and the contents has been denoted with the red color, and actually all important by the name only it is called as the occipital triangle. So it will contain occipital lymph node, it will contain occipital artery, it will contain spinal accessory nerve. Actually spinal accessory nerve is a very important content of occipital triangle. The spinal accessory nerve is sandwiched between the roof and the floor layer, and it is giving innervation to sternocleidomastoid and trapezius muscle. So we have got spinal accessory nerve. We have also got the other contents, like we have got the four branches of the cervical plexus cutaneous branches is the content. We have got the C3 C4 nerves. We have got the dorsal scapular nerves, and we have got the superior occipital lymph nodes, and sometimes superficial transverse cervical artery. In the lower triangular space, which content has been shown with green color, that is the space which is the subclavian triangle, which is also called as supraclavicular triangular space. And in the supraclavicular triangular space, again you can see the trunk of brachial plexus lies the third. So actually the third part of subclavian artery and the branches like subclavian vein. Also the lymph nodes. We have got the superficial transverse cervical dorsal scapular arteries. All these are important structures residing. So that is the nerve to subclavius and suprascapular nerve. That is the nerve of upper trunk of brachial plexus. So I just want everybody to write the details of contents. So please focus on this topic, contents of posterior triangle. So please write down contents of posterior triangle. Content of posterior triangle. So firstly you can write the contents in occipital triangle. Content in occipital triangle, and in the B part you can write the content in the subclavian triangle. Content in the subclavian triangle. which is also called as supraclavicular triangular space. So these two contents you have to understand. Okay, so let's start. So the contents are, if I talk about spinal accessory nerve, please write down the important content. Most important content is spinal accessory nerve. Actually, the spinal accessory nerve is prone to get injured in the posterior triangle. Why? It is more injured in the posterior triangle because of its location. It is exactly traversing between the roof and the floor layer. It is passing between the investing layer and the prevertebral layer of deep cervical fascia. It is plastered in between these two layers. So whenever there is any case of drainage has to be done, any abscess is there in the posterior triangle, any lymph node has to be dissected out or has been operated in this area, there can be a chance of injury of spinal accessory nerve. The other nerves are third and fourth cervical nerves. Third and fourth cervical nerves. Then we have got dorsal scapular nerve. Then we have got the forecutaneous branch of cervical plexus. We have got forecutaneous branches of cervical plexus. We have got forecutaneous branches of cervical plexus. Then we have got superficial transverse cervical artery. Superficial transverse cervical artery. Other than that, we have got occipital lymph node and occipital lymph node and occipital artery. Actually, the forecutaneous branch of cervical plexus name I have not written because we already have mentioned that 4 branches: transverse cervical, supraclavicular, great auricular, lesser occipital in the roof part. Okay. Now coming to the contents of the subclavian triangle. So if we talk about the contents of subclavian triangle, you can just write down the content of subclavian triangle. In the subclavian triangle, we have got the third part of subclavian artery. We have got the subclavian vein. We have got the terminal branch of external jugular vein, terminal branch of EJV, external jugular vein. We have got the trunks of brachial plexus as the content. We have got trunks of brachial plexus as the content. We have got the lymph nodes, supraclavicular lymph nodes. Actually, the branches of the trunk of brachial plexus, that is the nerve to subclavius, and we have got nerve to subclavius, and we have got suprascapular nerve. Okay, and also the arteries sometimes. So arteries are also there. That is the suprascapular artery, dorsal scapular artery, superficial transverse cervical artery. So all these are also the contents. So basically important contents you have to know. So we have done with this. Now I would like to talk about anterior triangle. So everyone, can we go to the next, that is anterior triangle? Okay, third and fourth. Okay, third and fourth is giving branch 2. So a question has arisen, yes dear, third and fourth. So yes, third and fourth cutaneous cervical nerves, no, you want to know. Third and fourth cervical nerve is giving innervation to levator, scapulae muscle and trapezius muscle. So is it okay? Shahil? No, it's what is a question asked by Venkatesh. Venkatesh, third and fourth nerve is giving innervation to the scalenus muscle and also giving innervation. So exactly, it is also giving innervation to the muscle of the trapezius muscle. So it is giving levator scapulae. It is giving innervation to levator scapulae and trapezius muscle. Okay. Now anterior triangle. So let's focus on to the next topic, that is anterior triangle. So anterior triangle is another very important triangle which you have to know. So individually you have to know about the 4 triangles which is lying inside, but before starting the individual triangle, I would like to show you this image. So just enlarge this image. So when I am enlarging this image, you can see the dotted line which has been shown to you, the black dotted line which is showing you the whole boundary for the anterior triangle. So anterior triangle is bounded. So you can see here the anterior boundary is by the anterior median neckline. So it is bounded anteriorly by the anterior mid neckline. It is bounded by the anterior mid neckline. It is bounded by the anterior mid neckline anteriorly, and it is bounded posteriorly by sternocleidomastoid muscle. The base is lying above, which is formed by the lower border of mandible, and an imaginary line drawn to the mastoid process. So an imaginary line going towards the mastoid process, this hole is forming the base. This hole is forming the base. The apex. So if I talk about the apex is lower down. The apex is lower down, which is at the level of suprasternal notch. So this is at the level of suprasternal notch. This is at the level of suprasternal notch. So this is the overall boundary of anterior triangle. So you can just write on the boundaries. Write on the heading boundaries. So anteriorly it is bounded by anterior mid neckline. Posteriorly it is bounded by the sternocleidomastoid muscle. Apex is formed by the suprasternal notch. Base is lying in the above direction and is formed by the lower border of mandible. Base is formed by the lower border of mandible. And an imaginary line extending to the mastoid process of extending to the mastoid process of temporal bone, extending to the mastoid process of which bone? Of the temporal bone. So done. Now I just want everybody, actually the main thing which everybody has to understand is the subdivision of anterior triangle, because individually you have to understand the triangular spaces, and individually I will talk about the triangular spaces and the details. So that is very important for you. Okay. So actually there is a muscle, that is the posterior belly of digastric. So there is digastric muscle, there is superior belly of omohyoid. So superior belly of omohyoid, digastric muscles are dividing the whole triangular area of anterior triangle into 4 subtriangular area. Into how many subtriangular area? Into 4 subtriangular area. So I first want to define. So this is sternocleidomastoid muscle. So let me just. So exactly this is sternocleidomastoid muscle. This is the anterior neckline, and this is actually the mandible lower border going towards the mastoid. So black outline which you are seeing, which I have marked here, is the whole of the boundary for the anterior triangle. So you can see whole of the anterior triangle I have marked out. So no worries about this. Let me just check with the students. So exactly, everybody, if you have got any doubt, yes, you are right, Sahil. So exactly, if I talk about the overall boundary of anterior triangle has been so. Now I want you to know about the subtriangular spaces. For example, pink color area which you are seeing, actually this is one half of a triangular space, that is submental triangle. Which triangle is this? This is the submental triangle. So wait a minute. So I am talking about this triangular space. This is the submental triangle area. Okay, this one half of the submental. So actually below the symphysis menti, what is this? This is symphysis menti. On both the side here, there will be a complete subtriangular area. And this is lying below the symphysis menti, but it is lying above to this bone. Which bone is this? This is the hyoid bone. So this is H for hyoid bone. So this is lying above the hyoid bone. So it is lying above hyoid bone. So this is lying above hyoid bone. Okay, this bone I will use gray color for it. This is the hyoid bone. Done. Now there is a green color triangular area. So exactly this triangular area we are talking about, this triangular area. This green color triangular area which has been shown here, this is the next triangular area, that is submandibular triangular area. Actually submandibular triangular area is also called as digastric triangular area, and it is bounded by the anterior. So actually in between the two anterior bellies of the digastric muscle, the small triangular space which is lying above hyoid bone and below symphysis menti, that is submental triangle area. Yeah. So exactly the base of the mandible and the line going towards the mastoid process, below it here we have got a triangular area. Here this area, this is called as digastric triangular area or the submandibular triangular area. So exactly lower to it, you can see the bellies of the muscle. So this is the digastric muscle belly and stylohead. So this muscle bellies are forming the boundaries, and this is the anterior belly of digastric muscle. So you can see here the two digastric muscle is there, and the yellow color triangular area which you are seeing here is the muscular triangle area. Actually this muscle belly is the superior muscle belly of the omohyoid muscle, which is participating in the division of the anterior triangle. Now, and the blue color triangular area which you are seeing is the carotid triangular area, which is lying anterior to sternocleidomastoid muscle and in between the superior belly of omohyoid and the digastric muscle. So don't worry, individually also I am going to tell you about the boundaries. So this was just a overall subdivision of the triangular areas of the anterior triangle, but overall I will give you the individual definitions of the boundaries of the triangular area. So four triangular areas are there. Let's start with the first triangular area, which is called as submental triangular area. Which triangular area? I am talking about submental. So let me just enlarge it. Can everybody appreciate the submental triangular area? Okay. So exactly you can see this small triangular. So this is the mandible bone. And this is the hyoid bone. So what you can see that exactly below the mandible. So exactly this is the area. This is the mandible bone and this is the hyoid bone. Exactly below the mandible, in between the two side anterior belly of digastric muscle. We are talking about the anterior belly of digastric muscle. So this is exactly this green muscles which you are seeing here are the anterior belly of digastric muscle. These are anterior belly of digastric muscle. So these are anterior belly of digastric muscle, and above the hyoid bone we have got which triangle? We have got the submental triangle. And what is important for your examination is to know the contents of submental triangle and the boundaries. Is it okay? So let's talk about the submental triangle. So I just want to enlarge this and I want everybody to write the details of submental triangle. You have to know about the boundaries and the content. So on each side it is bounded by anterior bellies of digastric muscle. Anterior bellies of digastric muscle. Anterior belly of digastric muscle. Base, body of hyoid bone. Apex, symphysis menti. So done. So these are all about the boundaries. So these are all about the boundaries of submental triangle. So these are all about the boundaries of submental triangle, and the next is to know the content of submental triangle. And next is to know the content of submental triangle. The content of submental triangle is so the roof is formed by, if I talk about the roof, so if I talk about the roof is formed by investing layer of deep cervical fascia. Roof is formed by investing layer of deep cervical fascia. So roof is formed by investing layer of deep cervical fascia, and the content is submental lymph node and that of submental lymph node, and also the vein which is commenced and formed here is anterior jugular vein. So it contains submental lymph node. It contains submental lymph node. It contains commencement of anterior jugular vein. So the submental lymph node, the anterior jugular vein, all these are the contents for the submental triangle. Now I just want also that you should know the floor of submental triangle. So it's also important. So this is about the roof, this is about the content, and what about the floor? So can you please note down the floor? So if I talk about the floor of submental triangle is formed by just one muscle, that is the mylohyoid muscle, and which is meeting in the midline to form mylohyoid raphe. So the floor is formed by mylohyoid muscle. Mylohyoid muscle, and it is meeting in midline to form mylohyoid raphe. Done? Done everyone. So the next thing is to know the next triangular space which I want everybody to understand is the digastric triangle or the submental triangle. Okay dear, if anybody, so is the pace okay? Is the pace okay? Should I go more faster or is it okay? Are you able to understand? Now the next triangular space is the digastric triangle, which is also called as submandibular triangular area. Digastric. Okay, so very good. So study, everyone was telling me to go slow. Today they are telling okay. So here Venkatesh is telling okay, you can go at a faster rate. Very good. Study, everyone was telling please go slow. So only I started slow. So okay. The other name of digastric triangle is, can anybody tell me, median raphe? Okay, you are not under, so Hassan is asking what is median raphe. Actually, if two muscles meet in the midline, the fibers which is interdigitating. So the fibers of interdigitating muscles is called as median raphe. Hassan, I will show you an image for it. So if you will see this image, this is about the submental triangle. So Hassan, can you appreciate here? See here, Hassan. So you can see these fibers are meeting in the midline. So if you will see the muscle fibers of the two-side mylohyoid muscle is meeting in the midline. So if you will see the muscle fibers are meeting in the midline, I should use black color so that you can understand. See here. So you can see the fibers are meeting in the midline, and these meeting of the mylohyoid fibers together is called as median raphe. So Hassan, is it okay? Have you understood? Okay. Now let's talk about the digastric triangle. The other name of digastric triangle is submandibular triangle. So I will go slide faster because everybody is okay for it. So you can see this is the mandible bone lower border. This is the this is the anterior belly of digastric. This is the posterior belly of digastric along with the stylohyoid muscle, and this is the hyoid bone. So this triangular area which you are seeing is the submandibular triangular area or the digastric triangular area. So I just want everybody to quickly write it because yes, we have to finish many topics. So I want to be slightly faster. So let's write the boundaries of digastric triangle. Boundaries of digastric triangle. So the boundaries are antero-inferiorly it is bounded by anterior belly of digastric muscle. Okay. Postero-inferiorly and if I talk about postero-inferiorly it is bounded by posterior belly of digastric. It is bounded by posterior belly of digastric muscle. And this is supplemented by one more muscle, and the name of that muscle is stylohyoid muscle. The name of that muscle is stylohyoid muscle. Now coming to the base. The base is formed by the base of mandible. Base of mandible and the imaginary line which is extending till the level of mastoid process. So I think plus the mastoid process imaginary. So I think it is known to you. This is an imaginary line extending till the level of mastoid process. Apex, if I talk about apex, the apex is formed by intermediate tendon of digastric muscle. So done. So here we have done with the boundaries of digastric triangle, and now I want everybody to note down the floor. So floor muscles, you can see these are the floor muscles. So you have to know about the floor muscles, and the floor muscle of digastric triangle are, so then we will come up with the content. So the floor muscles are, please write down the floor of digastric triangle. Floor of digastric triangle is formed by mylohyoid muscle, hyoglossus muscle, and that of middle constrictor muscle posteriorly. Now, what about the content? So, if I talk about the contents, as the name only suggests, the digastric triangle will have submandibular triangle. So, the digastric triangle is having submandibular gland. It is having actually the content of the digastric triangle or the submandibular triangle can be categorized as the content lying in the anterior part and the content lying in the posterior part. If I talk about the content in the anterior part, it contains submandibular gland, it contains submandibular lymph node, it contains hypoglossal nerve, it contains facial vein, facial artery, the submental artery, mylohyoid nerves, and the vessel. When we will proceed more posteriorly, it will have the external carotid artery, the part of the carotid sheath also, and the structures which is passing in between the external and internal carotid artery. So we will write the important content. So I just want you to show this cadaveric image. In this cadaveric image, you can see the outline of the submandibular gland, which is an important content for the digastric triangle. You can also appreciate the facial artery as the content. You can also appreciate the facial vein as the content. You can also appreciate the mylohyoid muscles, and you can see other important contents also has been shown. So see here the important, so you can, important content which I want everybody to note down here is the nerve. So we have got hypoglossal nerve. So you can see this is the hypoglossal nerve, which is an important content. We have got mylohyoid nerves and the vessel. Nerve to mylohyoid is there. These are all important. So we can see here important contents of the digastric triangle is being shown. So we are seeing the hypoglossal nerve, we are seeing the mylohyoid nerve to mylohyoid nerves, and we can also see the other contents here as the submandibular gland, the facial vein, facial artery. We can see the facial vein and facial arteries. Okay, so all the important contents of the digastric triangle is done. So let me just write quickly. Everyone, is it okay? Can we write quickly the contents? So the contents are contents of the anterior part. The contents of the anterior part. Yes. So the contents are submandibular gland, a very important content. Submandibular lymph node. Hypoglossal nerve. Facial vein, facial artery. Facial vein is there, the facial artery is there. As the content, we have got submental artery. We have got mylohyoid nerves in the vessels. Mylohyoid nerves in the vessels. All these are the contents. Other than that, content in the posterior part. Now, in the posterior part of the digastric triangle, we have got other important contents like a part of ECA, external carotid artery, will be seen. A part of carotid sheath and its content will be visualized. And a part of structures between structures ECA, external carotid artery, and that of ICA. Actually, that all stelloid structures and all will be seen. Related structure. The next triangular space is, so exactly I will just check. Is it okay? Important contents only you have to know. Yes, yes, dear, caudal part of parotid gland is also there. Yes, yes, Vankatesh, you are right. The caudal part of parotid gland is also there. Absolutely correct. Yes, a thumbs up goes for you. That is also correct. Yes, that is also correct. But I just want everybody to focus on the most important content because that is highly important for you to know. So can you see this triangular area outline? That is the carotid triangle. So this triangle is the carotid triangle, which is bounded by following muscle. So it is bounded by sternocleidomastoid muscle, the stylohyoid, digastric, and also the superior belly of omohyoid. So all of you please write down the carotid triangle boundaries. So carotid triangle boundaries. Superiorly, carotid triangle boundary. So superiorly it is bounded by posterior belly of digastric, and it is supplemented by stylohyoid muscle. Antero-inferiorly, if I talk about antero-inferior aspect, so antero-inferiorly, if I talk about the boundaries of the carotid triangle, it is bounded by superior belly of omohyoid. Posteriorly, it is bounded by anterior border of sternocleidomastoid muscle. Anterior border of sternocleidomastoid muscle. Okay. Now the next thing is to know the root. I would like everybody to know the important contents, which is very important for you. And also you have to know the floor muscle. You have to know the floor muscles and the roof. So I am not telling the roof one by one for every individual triangular space. The reason is that because we already know that the roof is formed for the both anterior and posterior triangle. The roof is formed by investing layer of deep cervical fascia. So I am not writing it once again. Okay, please write on the floor structure. So please write down floor, heading floor of digastric triangle. If I talk about the floor of digastric triangle is containing 4 muscles. It contains thyroid muscle. It contains thyroid muscle. It contains hyoglossus muscle. It contains middle constrictor muscle. It is formed by middle constrictor muscle. It contains inferior constrictor muscle. It contains inferior constrictor muscle. It contains inferior constrictor, hyoglossus and thyroid muscle. So done with this, these are the floor structures. Now other than that, let's talk about the content. So if I talk about the content of the carotid triangle, why it is one more point I want everybody to understand, the carotid triangle is mentioned as carotid triangle. The reason is why, because it is containing all carotid arteries. It is containing common carotid artery, it is containing internal carotid artery, it is containing external carotid artery, it is containing carotid body, carotid sinus, it is containing last 3 cranial nerves, that is 10th, 11th and 12th. It is containing ansa cervicalis, is a nerve loop which is embedded in the anterior wall of carotid sheath. It is containing deep cervical lymph node and cervical part of sympathetic chain. So exactly, you can see overall many important things has been as a content. So you can see the actually carotid sheath is containing internal jugular vein, carotid artery and vagus nerve. So blue color structure is internal jugular vein, then we have got the common carotid arteries, we have got the vagus nerve. These are the image where you can see the internal jugular vein, you can see the hypoglossal nerve, you can see the also the common carotid artery, external and internal carotid arteries here. So here is a schematic diagram to make you understand the content. So what you can see, important contents of the carotid triangle which is shown in this image will be the vagus nerve has, so exactly last 3 nerves, vagus nerve is there, the hypoglossal nerve is there and the accessory nerve is there. We have got all the carotid arteries, we have got the branches of carotid arteries are also, we have got 5 branches of the carotid artery which is a content. So the branches are facial artery, lingual artery, superior thyroid artery, ascending pharyngeal arteries, occipital artery. So you can see lingual, facial, superior, these are the 3 anterior branches, occipital and ascending pharyngeal arteries are there, and we have got the ansa cervicalis embedded in the anterior wall. So quickly write down the contents of carotid triangle. So the important contents are, it is called as carotid triangle because all carotid arteries are the content. So it contains common carotid artery. It contains common carotid artery. It contains external carotid artery. And its branches, if you want, you can write the important branches also. It contains internal carotid artery. So in other words, you can say all the important arteries, carotid arteries is the content of the carotid triangle. It contains superior thyroid artery. It contains facial lingual artery. Facial artery is there, lingual artery is there. There is also ascending pharyngeal artery and occipital artery. So all these are the contents for the carotid triangle. Other than that, it contains last 3 cranial nerves. So when I am using the word last 3 cranial nerves, it means it is containing the vagus nerve, it is containing the spinal accessory nerve, the 11th cranial nerve and it is containing the 12 hypoglossal cranial nerve. It also contains carotid sheath and its contents. Carotid sheath. So we have got three contents of the carotid sheath: vagus nerve, IJV, carotid artery. Other than that, it contains carotid body, it contains carotid sinus. Other than that, it also contains ansa cervicalis. It also contains the deep cervical lymph nodes, and it contains the cervical sympathetic chain. Cervical sympathetic chain. So all these structures are the contents of carotid triangle. All these structures are the contents of carotid triangle. Now I just want everybody, I just want everybody to know also about if I want to talk about the important part, so I just want everybody to know the details of accessory now. Okay. Exactly, accessory nerve is also in the anterior triangle. Yes, you are right, it is also in the anterior triangle. And other than that, I would also like to tell you about, if I talk about, I just want everybody to also know about ansa cervicalis. Okay. So exactly, if I talk about ansa cervicalis, it's a nerve loop which is embedded in the anterior wall. It is actually embedded in the anterior wall of the carotid sheath. So it's embedded in the anterior wall of carotid sheath. So let me just check. So yes, accessory nerve, yes, it is actually, we have got this as an anterior triangle and this as a posterior triangle. So it is in the part of carotid triangle also, and then it is traversing through the posterior aspect, through the middle of the posterior aspect of sternocleidomastoid muscle and giving innervation to sternocleidomastoid and trapezius muscle. Is it okay, Venkatesh? So it is traversing in the part of the carotid triangle of the anterior triangle, and then it passes into the plastered in between the investing and pre-vertebral layer of deep cervical fascia, and it is giving innervation to the two muscles, sternocleidomastoid muscle and the trapezius muscle. Is it okay, Venkatesh? Okay. Now, one of an important thing which I want everybody to understand is the ansa cervicalis loop. It's a nerve loop. It's a nerve loop which is embedded in the anterior wall of carotid sheath, and it is formed by, so exactly you can see the lower limb of ansa cervicalis is formed by C2, C3, and the superior belly. So exactly if I talk about the upper limb of ansa cervicalis, it is formed by C1, which is running along with the hypoglossal nerve. So actually all the infrahyoid muscle is supplied by the ansa cervicalis nerve loop except thyroid, because thyroid is supplied by the hypoglossal nerve which is running along with C1. So this is the odd man out. So ansa cervicalis nerve loop is, ansa cervicalis is embedded in, it is embedded in the anterior wall of carotid sheath. It is embedded in the anterior wall of carotid sheath. Okay, and it is formed by, so it's superior root. It is having a superior root. It is having an inferior root. It is having a superior root and inferior root. Superior root, अगर हम superior root की बात करें तो if I talk about the superior root, it is formed by the C1 nerve fibers running along with hypoglossal nerve, and C2 and C3 is inferior nerve. So it runs along with the hypoglossal nerve. Okay, run along with the hypoglossal nerve. So C1, and the other important point is all the infrahyoid muscle, all the infrahyoid muscle. So infrahyoid muscle cells, sternohyoid, sternothyroid, omohyoid, all are supplied by the ansa cervicalis nerve loop except thyroid. This has been asked several times in the examination. So all the infrahyoid muscle is innervated by ansa cervicalis nerve loop, ansa cervicalis loop except thyroid muscle. So exactly, thyroid muscle is not innervated by the nerve loop, it is innervated by C1 nerve which is running along with the hypoglossal nerve. So this is not exactly innervated by the loop of ansa cervicalis. Now the other important point is, as I told you, I just want everybody to see this image. Actually in this image you can appreciate the location of nerve loop and yes, good afternoon dear. So exactly what you can see, if we are talking about, so it is lying on the anterior wall of the carotid sheath. So exactly I am using this. This is the carotid artery. This is the common carotid artery. Actually, this is the carotid artery which has been shown. This is the carotid artery, no doubt about that. Now, other than that, you can see the jugular vein also. This is internal jugular vein. And this is the vagus nerve. Okay. So, these are the contents of ansa cervicalis, and anterior to it, the nerve loop is traversing, and you can see here this is the nerve loop which is traversing anterior to it. This is the nerve loop which is traversing anterior to it, and this nerve loop is so this is SR, this is the superior and this is the inferior nerve root of this nerve loop is ansa cervicalis nerve loop, which is lying anterior to the content of carotid sheath. This is lying anterior to the content of carotid sheath. Okay, done with this. Now now I would like to talk about the last triangular space in context of the muscular triangle. So you can see the yellow color triangular area which has been outlined here. This is triangular area which you are seeing is the so this triangular area which you are seeing is the muscular triangular area. This is the muscular triangular area, and if I talk about the boundaries of this muscular triangular area, it's important to know the boundaries. It's important to know the boundaries, and it's also important to know the content. So the first thing is that why it is called as muscular triangle, because no neurovascular structures are residing. It is bounded anteriorly by the anterior mid neckline, anterosuperiorly by the omohyoid muscle. So anterosuperiorly by the omohyoid muscle, superior belly of omohyoid muscle. And if I talk about posterior-inferiorly by sternocleidomastoid muscle anterior border, this is the boundary, and it contains muscles. It contains actually infrahyoid muscles, sternohyoid, sternothyroid, and thyroid muscles. These are the muscles which is forming floor and the content of muscular triangle. So please write down about the muscular triangle. First thing is to write the boundaries. And the boundaries of muscular triangle is, it is bounded anteriorly by the anterior median neckline, anterior median neckline. It is bounded anterosuperiorly by, it is bounded anterosuperiorly. If I talk about anterosuperior aspect, so anterosuperiorly it is bounded by superior belly of omohyoid, superior belly of omohyoid muscle. It is bounded by superior belly of the omohyoid muscle, and posterior-inferiorly it is bounded by, posterior-inferiorly it is bounded by the sternocleidomastoid muscle. To be more specific, it is bounded by anterior border of sternocleidomastoid muscle. So it is bounded by, anterior border of sternocleidomastoid muscle. So done with this. So if I talk about, so exactly if I talk about the content and the floor. So if I talk about the content and the floor, are similar. So you, if you will see, this is the muscular triangle which we are talking. No, this is the muscular triangle. So exactly in this muscular triangle, we have got the muscles only. We have got sternohyoid, sternothyroid, and thyroid muscle, which is similar. The floor and the content is similar. So please write down. Please write on the heading content and floor of muscular triangle. Content and floor of muscular triangle. So if I am talking about the content of the floor and muscular triangle, these are similar. So it is having the content and floor as a similar structures. Three important structures are lying there. They are sternothyroid muscle, sternohyoid muscle, and that of thyroid muscle. Thyroid muscle. Okay. So is it okay? Anything which you are, yes, good afternoon, Mr. Ramu, but I just want, if you are not understanding anything, just let me know. Please let me know. Now we have finished with all anterior posterior. Two more triangular space I want you to tell, because these are the other two important triangular spaces in brief. One is the scaleno-vertebral triangle. So if I talk about scaleno-vertebral triangle, you can just see here. This is the muscle which is the longest colli muscle. This is the longest colli muscle which you are seeing. This is longest colli muscle, and this muscle is scalenus group of muscles. This is the scalenus group of muscles. We have got scalenus group of muscles. So exactly in between scalenus muscle, longest colli muscle, and inferiorly we have got the subclavian artery. Inferiorly we have got the subclavian artery. So exactly in between the subclavian arteries, in between the scalenus muscle, and in between the longest colli muscle, the triangular space which you are seeing, so I am just talking about this triangular space. If you want, I can use this triangular space. So this triangular space I am talking, this triangular space which I have shaded in slight green, that triangular space is scaleno-vertebral triangle, and it is having the first part of the vertebral artery residing in this area. So scaleno-vertebral triangle is bounded by longest colli muscle. It is bounded by scalenus muscle and inferiorly by subclavian artery. And it contains first part of, it contains scaleno-vertebral triangle contains first part of vertebral artery as the content. Okay. Now, basically, I just want everybody to note down the important point only. So here you can see again, if you will see this image, you can understand. So here once more I want to show this image. This is the scalenus muscle, scalenus anterior. This is longest colli muscle. Okay, this is the subclavian artery. So this is the subclavian artery. Okay, this is the subclavian artery. So there is a subclavian artery, there is a scalenus anterior muscle, there is longest colli muscle which is forming the boundary, and the content which is lying inside is the vertebral artery. So most important content is the vertebral artery which is lying inside. Also you can see in the left side there is the content. So in the left side there is thoracic duct. Also here we will have the stellate ganglion. So all these are the content for the scaleno-vertebral triangle. Now I would like to talk about the next triangular space. So here we can have more of the images to understand. So actually in the left side, I just want to note down important. In left side, scaleno-vertebral triangle contains thoracic duct. Also it is related to stellate ganglion. And one more structure is there, that is actually here you can see in this triangular area there is one ansa subclavia which is also the content. There is a cervical ganglion also the content, and there is also the ansa subclavia. I will talk about ansa subclavia also, which is the content. Now I just want everybody to see this cadaveric image. Actually this cadaveric image is importantly showing the most important content. So what is basically important for us is to know the most important content. So I just want here, this is the subclavian artery. This is the vertebral artery. This is the subclavian artery. This is the vertebral artery. And here this is the longest colli muscle. This is the longest colli muscle. This is the scalenus anterior muscle. So this triangular space which we are talking is the okay. Okay, just a minute. I just want to rub this. Okay, so I'm talking about this triangular area. So if we are talking about this triangular area, yeah. So this is subclavian artery, and the structure lying inside is the structure which is lying inside is the vertebral artery. So you can just use this color. This is VA for vertebral artery, and this is SA for the subclavian artery. So these are the structures. So this triangular area which you are seeing is the scaleno-vertebral triangular area. So this triangular area is scaleno-vertebral triangular area. Yes, now I just want that in this triangular area we have also got the one important nerve loop, that is ansa subclavia. So an important nerve loop is there, that is called ansa subclavia. I would like to talk about ansa subclavia. So actually ansa subclavia is called as subclavian loop, and it is also called as Viosens ansa. It's a nerve cord connection between, it's a nerve cord connection, and this nerve cord connection is lying between the middle and the inferior cervical ganglion. So exactly this is lying between the middle and inferior cervical ganglion, and it is commonly fused with the first thoracic ganglion, and it is called as stellate ganglion. So exactly when we talk about the nerve cord connection which is taking place between medial and inferior cervical ganglion, it gets fused with the first thoracic ganglion and lead to the formation of stellate ganglion. Is it okay? So this is exactly the content. So this is also the content of the scaleno-vertebral triangle. Scaleno-vertebral triangle. Got it, everyone? Got it? Now, one of an important triangular space which is very, very important. So many questions has been asked from this topic. So exactly you have to also know, if any of the students is not understanding anything, please let me know. Okay, if you are not understanding anything, please let me know, my dear students. Okay. So next triangular space is is that of the suboccipital triangle, and you can see in this image I have just highlighted this triangular space which you are seeing is the suboccipital triangle. So exactly if I talk about this, this triangular space, we have to know about the boundaries. Okay, we have to know about the boundaries of it, and we have to know the important structures. Actually, subclavian triangular space, suboccipital triangular space has been asked so many times. It has been asked so many times in the examination. Okay. Okay, so exactly that is very important. So actually one of the student has asked me about stellate ganglion. So actually if I talk about stellate ganglion, it is a collection of sympathetic nerves which is found anterior in the neck region, and the important function is that it is giving, it is most important providing sympathetic nerve innervation to head, neck, arm, and also a part of upper chest. Okay, so it's a part of autonomic nervous system, and it is responsible for controlling many of the innervation in the area of head, neck, arm, and a portion of chest also. Is it okay? Is it okay, Venkatesh? So that is a function. Okay, that is a function. It is an important function for the innervation of the autonomic nervous system of the head and neck areas. Now, suboccipital triangular space, if you will see in this image, you can see the suboccipital triangular space which is having the boundary. So, it is bounded by rectus capitis posterior major as the supromedial, obliquus capitis superior. This is obliquus capitis superior muscle as the suprolateral boundary. Inferiorly, we have got the obliquus capitis inferior. So, these are the three muscle which is forming the boundary of suboccipital triangle. Medially, supromedially, rectus capitis posterior major, suprolaterally, obliquus capitis superior, inferiorly, we have got obliquus capitis inferior muscle. So, I just want everybody to write down the boundaries. So, one more image is there where different color has been used. So, here red color muscle is inferior boundary which is obliquus capitis, which is exactly obliquus capitis inferior muscle. Obliquus capitis inferior. This is the obliquus and the blue color muscle is rectus capitis posterior major, obliquus capitis superior is the green color muscle, and these are the three muscle forming boundary of suboccipital triangle. So, write down heading boundaries of suboccipital triangle. Boundaries of suboccipital triangle. So, if I talk about the boundaries of suboccipital triangle, you have to know the important structures forming the boundary. So, we have got following important structures. So, supromedially, it is bounded by rectus capitis posterior major muscle. Suprolaterally, it is bounded by obliquus capitis superior muscle. Obliquus capitis superior muscle. Inferiorly, it is bounded by obliquus capitis inferior muscle. Obliquus capitis inferior muscle. So, these are the boundaries of suboccipital triangle, and we have to know the floor and the content. So, if I talk about the floor structures are, so we have to talk about the floor. So, here itself you can see the floor structures. Floor of suboccipital triangle. Floor of suboccipital triangle is formed mainly by the two structures. One is posterior arch of first cervical. So, one is the posterior arch. So, please don't get confused with the third part of vertebral artery. It is not the floor, but it is the content. So, posterior atlanto-occipital membrane. So, two structures are forming the floor. One is the posterior atlanto-occipital membrane and the other is posterior arch of first cervical vertebra. We have got posterior arch of first cervical vertebra. So, this is the two structure. Just a minute. These two structures are forming the content of floor. So, we have got posterior arch of C1 and we have got posterior atlanto-occipital membrane. Posterior atlanto-occipital membrane. Now, the content is the third part of vertebral artery, the suboccipital venous plexus and suboccipital nerve. So, if I talk about the content, so in this diagram we can see the content. Content is suboccipital nerve, vertebral artery third part and suboccipital. So, you can see here this is the third part of vertebral artery which is residing inside. So, we have got the third part of vertebral artery, we have got also the suboccipital nerve and also suboccipital venous plexus as the content. So, please write down the heading content of suboccipital triangle. So, the content of suboccipital triangle is following. It contains suboccipital nerve, which is formed by the dorsal ramus of first cervi. So it contains suboccipital nerve as the content. So it contains suboccipital nerve as the content. It contains suboccipital venous plexus as the content. Suboccipital venous plexus as the content. And it contains third part of vertebral artery. It contains third part of vertebral artery as the content. Third part of vertebral artery. It contains third part of vertebral artery as the content. So you can see here all these structures which has been mentioned here is the content of suboccipital triangle. So done with this, one time the question which was asked in the previous year was the boundary of suboccipital triangle. That was supralateral boundary, and supralaterally it is bounded by obliquus capitis superior muscle. So we have finished all the triangular spaces of the neck. So we have finished this topic also. Now I want to tell you about the important arteries. So everyone, can we proceed with the next category? All the arteries, all the important arteries of the head and neck series. So all the important arteries of head and neck series is, we have to know about the branches of external carotid artery. We have to know about the branches of maxillary artery. We have to know about the branches of facial artery. These are the few important arteries which is very, very important for you to note down. So exactly, if I talk about external carotid artery, it is a branch of common carotid artery. The bifurcation of external carotid artery and internal carotid artery from common carotid artery takes place at the level of C4 cervical vertebra. So exactly, it takes place at the area of C4 cervical vertebra. External carotid artery is a very important artery. It is giving arterial supply to head and neck region. And internal carotid artery will give blood supply to that of the brain area. So done with this. Now I just want everybody to note down the important branches of external carotid artery. There is a mnemonic to know the branches of external carotid artery. What is that mnemonic? That mnemonic is, some anatomists like freaking out poor medical students. Some anatomists like freaking out poor medical students. So you have to know about the branches in the same way. Okay, so you have to know all these are very important. So actually in carotid triangle, it gives following branches. So it gives superior thyroid artery as one of the anterior branch, ascending pharyngeal artery is the medial branch, lingual artery is an anterior branch, facial artery is also an anterior branch, occipital posterior auricular arteries are actually the branches from the posterior part. And we have got two other branches, maxillary and superficial temporal. These are the terminal branches. So here in this diagram, all the branches of external carotid artery has been shown to you. So everyone, as you can see here, so exactly in this condition, if I just want to yeah. So exactly if I talk about superficial temporal and the maxillary artery, okay, other are giving other mnemonic. Okay, so I will give my own other mnemonic which I like. So superficial temporal, very good dear, very good Osama. So superficial temporal and maxillary are the two terminal branches. So these are two terminal branches. Okay, the posterior and the occipital. If I talk about posterior and occipital, these are two posterior branches. These are two posterior branches of external carotid artery, facial, lingual and superior thyroid. These three are the anterior branches. These three are the anterior branches of external carotid artery. And we have got just one medial branches. We have got just one medial branch, that is ascending pharyngeal artery. So one medial branch of external carotid artery is the ascending pharyngeal artery. So all these are the branches of external carotid artery. So next important point is to write this. So exactly, I just want everybody to write a mnemonic for it. So write down the mnemonics. So write on the mnemonic. Yes, you are right, Venkatesh. Some anatomist like freaking out poor medical students. So this is a mnemonic for the branches of external carotid artery. So here we have got S for superior thyroid artery, here A for ascending pharyngeal artery, L for lingual artery, F for facial artery, another O and P for occipital and posterior auricular artery, posterior auricular artery, M for maxillary artery, and another S for superficial temporal artery. So exactly here together you can get 1, 2, 8 branches. So all these are the branches of external carotid artery. Done with this. Now I just want everybody to know with the other artery, that is maxillary artery. So as we know, maxillary artery is one of the terminal branches of external carotid artery, and maxillary artery branches are very important. So maxillary artery branches are very important. So exactly, maxillary artery is divided into 3 parts by a key muscle in the infratemporal region, and the name of the key muscle in the infratemporal region is lateral pterygoid muscle. Lateral pterygoid muscle is dividing maxillary artery into 3 parts. It is dividing into 3 parts, first, second and third. The first part is lying exactly in the mandibular part. It is also called as mandibular part. Actually, it is lying the first part will be lying above lateral pterygoid. So exactly, it is traversing towards, it is starting from the neck of mandible to the lateral pterygoid muscle. Posterior to lateral pterygoid muscle is the second part, and the part of and the part of maxillary artery which is traversing to the pterygomaxillary fissure and to the pterygomaxillary area, that is the third part. So that means we have got 3 parts in the maxillary artery, and we have to know the branches of individual parts. So in this diagram you can see the key muscle of the infratemporal region. This is the upper and this is the lower head. So in this diagram, you can see the upper and the lower head of the lateral pterygoid muscle, and in correlation to these muscles, we have divided the maxillary artery into 3 parts. Actually, what is important for you to understand is that you have to know the branches from the individual component of maxillary artery. So there are very many mnemonics, but I think mnemonics is good, but you have to understand the branches so that you will this will remain in your functional area of the brain for long duration of time. So let's talk about the branches of first part of maxillary artery. So maxillary artery, first part. So first part is called as the mandibular part of maxillary artery, and you have to know the branches from this part. So the branches of these part, that is the branches from the mandibular part of maxillary artery is following, and the branches are actually there are 5 branches from the, so actually there are 5 branches from the first part. So actually there are 5 branches from the first part, and the 5 branches of the maxillary artery or mandibular part of maxillary artery is following. The branches are: 2 is towards the ear, 2 is towards the ear, that is anterior tympanic and deep auricular artery. So and one is middle meningeal artery, other is accessory middle meningeal artery, and the other is inferior alveolar artery. So exactly what I think I should firstly explain and then write it to you. So I just take a image for it. Yeah, see here. So actually this is a schematic diagram. This is a schematic diagram where the three parts of maxillary artery has been shown. So in the first part you can see this is external carotid artery and its two terminal branches has been shown. One is superficial temporal, this is superficial temporal, and the other is maxillary artery. So here is the first part. Okay. So we have got the first part of maxillary artery and we have to know the branches from the first part. So how many branches are there from the first part? So if I talk about the branches, 5 branches are there and I am just highlighting these 5 branches. So this is the first branch. Yes, many mnemonics are there. Many mnemonics are there. That is, so here Venkatesh is telling, "Damn, I am poor dreamer, but start dreaming. Prefer my path." So yes, you can make your own mnemonic. What I feel is how to remember the first part is we have got two going towards the ear, that is anterior tympanic and deep auricular. One is going inside the oral cavity, inferior alveolar artery. Two is going towards the meninges of the brain, that is middle meningeal artery and accessory middle meningeal artery. So exactly, if I want to tell about these branches, so we have got together 5 branches and these are the 5 branches. So here we have got deep auricular, we have got anterior tympanic, middle meningeal artery, accessory middle meningeal artery, and we have got inferior alveolar artery, which further divides into mental mylohyoid branches. Now I will use a different color for the second part branches. So I am using brown color for the second part branches because second part branches, the branches of second part of maxillary artery are all muscular. So why I have used brown color? All the muscles are in anatomy shown by brown color and all the branches of the second part is also muscular. So we have got anterior, posterior, temporal, pterygoid, buccal, buccinator, masseteric and pterygoid. So all these branches. So we have got branches to pterygoid muscle, we have got branches to the buccinator, we have got branches to the masseter and temporalis muscle. So all these exactly we have got anterior and posterior deep temporal, pterygoid, we have got buccinator and masseter. So all these branches are the muscular branches. And the third part, if I talk about the third part branches, the third part branches are 6 and also a terminal branch is given. So most of the branches of the third part is having P name attached to it. So one is the oddman, that is inferior orbital artery. Otherwise we have got posterior superior alveolar, we have got sphenopalatine artery, which is the terminal branch, artery to pterygoid canal, pharyngeal artery and descending palatine artery. So how you are going to remember, in the 6 branches, most of the branches is having P word attached to it. So we have got altogether how many branches? We have got 6 branches from the third part of maxillary artery. So we have got 6 branches from the third part of maxillary artery. So it's important that one by one you have to know the parts, branches, because the question will be asked like this. So let's talk about that. So first part branches, please write down the branches of the first part. So first part branches are deep auricular, anterior tympanic artery, yes, hello to you, anterior tympanic artery, yes, Mona Sharma, hello, middle meningeal artery, then we have got accessory middle meningeal artery, accessory middle meningeal artery, yes, yes, Balaji, hello, Venkatesh, yes, yes, you are absolutely right, it is the inferior alveolar artery. So altogether we have got the first part of the maxillary artery is called as the mandibular part of the maxillary artery, and this mandibular part of the maxillary artery is giving 5 branches. The deep auricular, the anterior tympanic, the middle meningeal artery, accessory middle meningeal artery, and inferior alveolar artery. Now talking about the second part. So actually I just want to elaborate one of the branch. Actually middle meningeal artery is clinically very important. If there is a direct hit or striking on the lateral aspect of the skull, it can lead to the bleeding from the middle meningeal artery. To be more specific, it's the anterior division, anterior trunk of the middle meningeal artery along with the sylvian sulcus, which is overlining on this area, and there can be a bleeding from this branch. So exactly you can see here, this is the middle meningeal artery, branch of maxillary artery, first part. And this is an H-shaped suture. What is this H-shaped suture called as pterion? So at the level of pterion, we have got the anterior trunk of the middle meningeal artery lying there. So if there is a hit or a direct struck on the lateral aspect of the skull, bleeding can occur from the middle meningeal artery anterior division, leading to epidural or extradural hematoma. So it can be injured at the level of pterion, and it can be bleeding from anterior division or trunk of middle meningeal artery can take place, and this condition will lead to epidural or extradural hematoma. So done with this? Yes, you are absolutely right, Venkatesh. EDH, extradural hematoma at the level of pterion. Yes, you are absolutely right. The same thing. Now talking about the next, so let's talk about the second part branches. So if I'm talking about the second, so if I'm talking about the branches from the second part, all muscular branches, you can just write all muscular branches, and these are the muscular branches to the adjoining area of the muscles which is lying nearby. So we have got deep temporal branch, we have got deep temporal artery, which can be again anterior and posterior. We have got masseteric artery, we have got pterygoid artery, we have got the buccal artery, buccinator branch, buccal artery. So all these are the branches from the second part of the maxillary artery, and all these are muscular branches. Now talking about the branches from the third part of maxillary artery. The third part of the maxillary artery is the pterygopalatine part, because it will traverse through the pterygomaxillary fissure, and it is giving 6 branches. How many branches it gives? It gives 6 branches, and it also gives the terminal branch. The name of the terminal branch is the sphenopalatine artery. Yes, Balaji, you are absolutely right. The second part branches are the muscular branches. Absolutely correct, Balaji. Now let's talk about the third part. The third part, it is giving 6 branches. And how to memorize these branches? So I would like to suggest that these all branches is having P word in this name, and only infraorbital is the odd man. Yes, Mona Sharma, you are absolutely right. The branches are posterior superior alveolar artery. Please write on the name. The names are as following. Posterior superior alveolar artery. Posterior superior alveolar artery. Again, it is having P name attached to it. We have got descending palatine artery. The descending palatine artery will further give 2 branches, the greater palatine and the lesser palatine artery. Then we have got Pharyngeal artery, artery to pterygoid canal, we have got infraorbital artery and sphenopalatine artery. So actually these are the 6 branches. So actually these are the 6 branches which is given from the, so exactly we have got the 6 branches. So exactly we have got the 6 branches which is actually given. So these are the 6 branches which is exactly given from the maxillary artery. So it's important that you should know all the branches name, and it's also important that you should know that the sphenopalatine artery is the terminal branch. So if I talk about sphenopalatine artery, it's the terminal branch of it's a terminal branch of maxillary artery. So you can just write down that. So just write sphenopalatine artery is the terminal branch. It's the terminal branch. It's the terminal branch. So now I just want everybody, so we have done, any of the students is having any doubt, please let me know. If you are having any doubt, please let me know. If there is any doubt, you are not able to understand anything, you can just note down. Is it okay everyone? Please let me know. I will just check. Okay, greater palatine artery infra. Yeah, yes. Balaji is telling greater palatine artery. Yes, you are right. Descending palatine artery further gives greater and the lesser palatine artery. Yes, I can understand that some of the students get confused with the word palatine artery, greater palatine. A few books have written as a greater palatine artery. I want to elaborate. The correct answer will be descending palatine artery, which further gives greater and the lesser palatine artery. So descending palatine artery is a direct branch from the third part, pterygopalatine part of the maxillary artery, which further gives the greater palatine or lesser palatine artery. Okay, Dr. Shifa. So Dr. Shifa is from Pakistan. Okay, okay, dear. Okay, so let's talk about. So yeah, it's good that from many different area and parts of the world, all of you are listening to this lecture. So I am so blessed. Now talking about the facial artery. So facial artery is another artery which is a very important branch of external carotid artery. It's a branch, it's an anterior branch of external carotid artery. And this facial artery, if you will see, it's giving branches onto the face, it is giving branches on the cervical region. So I just want to elaborate this image. So if you nicely appreciate this image, what you can see, the branches of the facial artery is having tortuous course. You can see this is the facial artery, which is a branch from the external carotid artery anterior branches. So it will give many branches, and it will be giving 4 branches in the cervical region, and it will give 4 branches in the facial region. So actually it is having a tortuous course. The facial artery is an anterior branch from external carotid artery. It passes over to the masseter muscle and then traverses towards the mandible, and it will run along the nasolabial fold towards the angle of the eye. So exactly it passes beneath the digastric muscle and passes through the muscle. Ultimately it passes through the submandibular gland. So actually what I want everybody is to understand the facial artery branches. It gives 4 branches on the face and it gives 4 branches in the cervical region. The 4 branches in the cervical region is tonsillar, submental, ascending palatine, glandular. So these are the 4 branches which is given in the cervical region, and 4 on the facial is the angular, lateral nasal, superior labial and inferior labial. So all these you have to know. These are the names of all the branches of the facial artery. So together how many branches are there? We have got 8 branches. Already we have talked about the epidural hematoma, and we have seen the bleeding occurs from the bleeding occurs from the middle meningeal artery which get injured at the level of pterion. So actually this is pterion where the middle meningeal artery ruptures and gives the case of extradural hematoma. Now I just want everybody, so everyone, I just want everyone to solve this MCQ. This is a clinical MCQ. I will give you 1 minute time or few seconds time, 30-40 seconds to solve this MCQ. A 23-year-old female, Caucasian female, is brought to the emergency room. She is unconscious when she is brought to the emergency room after a motor vehicle accident, and a linear fracture is seen in the area of the junction of 4 bones. The 4 bones junction is, so we have got 4 bones which junction is involved here, and that is frontal, parietal, temporal and sphenoid. So that is frontal, parietal, temporal and sphenoid. These 4 bones junction which is called as pterion, as I know I have just explained you. Can you tell me which of the following artery is severed at this location? Option is occipital, maxillary, ophthalmic, middle cerebral, sphenopalatine and facial. Can you tell me the answer? So I will give you few seconds. So I will give you few seconds. Please let me just check. Actually, I have just explained, and I think it will be easy for you to give the answer. So actually, the location where these 4 bones are meeting, that is called as pterion. That hint is given, and we know the artery can. So please write down the name of artery being involved. Firstly, write down the name of the artery being involved. So exactly the artery being involved is the, if I talk about the artery being injured, is the middle meningeal artery, and we know that the middle meningeal artery is a branch of which artery? Middle meningeal artery is a branch of maxillary artery. So definitely B is the right answer. Now let me just check with the students, are they able to understand or not? Okay. So yes, dear students, maxillary artery branch, middle meningeal. Yes, Dr. SK, you are absolutely right. The maxillary artery is the right answer. So directly they have not asked about the middle meningeal artery. In the option they have given the source of middle meningeal artery, that is the maxillary artery. So that is the right answer. Absolutely, 4 bones are meeting at this location, and due to the injury of these 4 bones located at the junction of this H-shaped suture pterion leads to the bleeding from middle meningeal artery, that is a branch from the maxillary artery. Now next topic is tongue. Okay everyone, so tongue is a very important topic for your competitive exam. So I just want to complete tongue. Is it okay? Should we start with the tongue? So after completion of tongue, I will give you a break of 25 minutes. We can take a break of 20 minutes, 25 if you want to have your lunch. Is it okay? Let me know. Dr. SK, Dr. Balaji, Dr. Mona Sharma, Dr. Venkatesh, Ajit, Balaji, everyone, those who are here. Can we have the session? So I just want to complete tongue and then I want to give the break. If you want now, you just let me know. So because that is important, that you should be, I'm going to start a new topic. It will take another 25 minutes and all. So yes, Oshma Sheikh. So everyone is okay if I complete tongue, or should you want a break? Let me know. So I should continue with the tongue. I think we should continue with the tongue. Is it okay with everyone? After completion of the topic of tongue, we can have a break. So tongue is a muscular organ, and it is made of skeletal muscle. It is made of fibrous septums. It is made of fat, lymphoid structure, and it is also having mixed glands. So this is the overall composition of the tongue. You have to know the gross anatomy of the tongue, and you have to know the detailed anatomy. So for that, I just want to enlarge this image. So when I am enlarging it, you can see the parts of the tongue are the root, tip and the body. We have to know the structures lying in the dorsum and inferior part of the tongue. We have to know about the tongue muscle. We have to know about the arterial supply of the tongue. We have to know about the nerve supply of the tongue, venous drainage, lymphatic drainage and the clinical anatomy. So if you see, this is the part of the tongue which is shown. This is the dorsum part of the tongue, and in the dorsum part of the tongue we have got tongue papillas. Okay, so exactly, I just want to firstly explain and then I will give you the details. So all of you please see this image. So all of you just see this image. If you see this image, you can appreciate. So what exactly is shown here is the dorsal part of the tongue. So when you see the dorsum part of the tongue, you can see there is a sulcus terminalis. Okay, there is a V-shaped sulcus terminalis. So this V shape is the sulcus terminal. Posteriorly, it will meet at a place that is called as foramen cecum. What will it called as? It will be called as FC. What is FC? It is called as foramen cecum. That is the remnant of thyroglossal duct. So that means this part which you are seeing will be the anterior 2/3 part of the tongue, and this part which you are seeing will be the posterior 1/3 part of the tongue. And it is important to know that what are the structures lying in the anterior part of the tongue and what are the structures lying in the posterior part of the tongue. So exactly, if I talk about the anterior part of the tongue, it is incorporated by different kinds of papillae. So different kinds of papillae is located here. We have got 4 types of papillae. We have got the filiform papillae. We have got exactly, I just want to highlight the papillae. So we have got following papillae. We have got circumvallate papillae, the largest papillae. These are the circumvallate papillae which is lying just anterior to sulcus terminalis. We have got filiform papillae which are very small papillae distributed overall area of the anterior part of the tongue. Fungiform papillae will be slightly larger than the filiform papillae, and it is in the anterior lateral aspect, and also rudimentary papillae is there. This is the rudimentary papillae which is called as the foliate papillae. So this is fungi, this is fili, this is circumvallate, and this is the rudimentary, which one is called as foliate papillae. So how many papillae are there? 1, 2, 3, and this is the 4th one. So we have got 4 papillae. Okay, so just in brief, you have to know about this papillae. The papillae will have, the tongue papillae will have taste bud, and that is important for taste sensation. The largest papillae is a circumvallate papillae lying anterior to sulcus terminalis, and it is having maximum number of taste bud. It is located just anterior to sulcus terminalis, anterior to foramen cecum. It is actually lying in the anterior part of the tongue, or you can say at the border of anterior and posterior part of the tongue. Posterior part of the tongue, if you will see on the dorsum aspect, it is incorporated with, you can see here, it is having incorporation of lymphatic aggregation, and this lymphatic aggregation is forming lingual tonsil. What it forms? It forms the lingual tonsil. So it is forming the lingual tonsil. What is it is forming? It is forming the lingual tonsil. Also in this diagram, you can appreciate that a lingual tonsil is posteriorly having an attachment with this epiglottis. What is this? Epiglottis. What is epiglottis, dear? Epiglottis is one of the laryngeal cartilage. So this attachment will be via median glossoepiglottic fold and lateral glossoepiglottic fold, and in between median glossoepiglottic fold and lateral glossoepiglottic fold, I have crossed here. This is the area of vallecula. Okay, so if I talk about overall epithelium lining of the tongue, it is stratified squamous non-keratinized epithelium, but only the odd man out is filiform papillae, which is having the keratinization, that is giving gritty appearance to the tongue. So yes, so here if I talk about, so I just want everybody to write few important things. Okay, so I just want everybody to include one of important features, the lining epithelium of the tongue. So lining epithelium of tongue is stratified squamous, non-keratinized epithelium. It is stratified squamous non-keratinized epithelium. So the lining epithelium is stratified squamous non-keratinized epithelium. Only the odd man out is the filiform papillae. So I just want to enlarge this, and I just want one or two important points to be written on this papillae. Okay. So here, if I talk about circumvallate or vallate papillae, it is the largest papillae. It is largest. Location is already explained. It is lying anterior to sulcus terminalis. It is having maximum number of taste buds. So it is having maximum number of taste buds. It's very tiny, and the filiform papillae is having keratinization. So that means it will have stratified squamous keratinized epithelium. It will have stratified squamous keratinized epithelium. Okay, the foliate is the rudimentary papillae. It is a rudimentary papillae. And fungiform papillae is also having taste bud, and it is actually so foliate is also having taste bud, but it is rudimentary in case of human beings. Okay, so that are the important points which you have to remember here. Okay, now exactly in the posterior part of the tongue. So this was about the anterior part of the tongue, which is having actually other than that, it is also tongue itself is made of muscles. So it is made of intrinsic group of muscles, and the muscle which is connecting the tongue to the neighboring structure is called as extrinsic group of muscles. And exactly if I talk about its posterior part, it is actually called as the pharyngeal part, and this pharyngeal part of the tongue is having the aggregations of lymphatic nodules, which is forming the lingual tonsil. What is forming lingual tonsil? The posterior part of the tongue is attached to if we talk about the posterior part of the tongue, it is attached to epiglottis. The posterior part of the tongue is attached to epiglottis. The posterior part of the tongue is attached to epiglottis by median and lateral glossoepiglottic fold. Glossoepiglottic fold. And in between the median and lateral glossoepiglottic fold, we have got the vallecula. The location is of vallecula. So we have got vallecula at this location. Now let's talk about the inferior surface. So we have done with the dorsum part of the tongue. Inferior part of the tongue will have few important things which you have to know. So we have to know about the inferior part of the tongue, which is highly important. So if any of the student is not understanding anything, they can ask me. Is it okay? Okay. Now inferior part of the tongue, you can see there is, okay, vallecula you are not understanding. Okay, one of the student vallecula you are not understanding. So let me just enlarge this image. Okay, you can see this is the epiglottis. What is epiglottis? Epiglottis means the laryngeal cartilage, and this is the elastic laryngeal cartilage, and in the midline you can see the connection of epiglottis with the posterior part of the tongue is via median glossoepiglottic fold, and laterally the attachment of the epiglottis to the posterior part of the tongue is by lateral glossoepiglottic fold. So that means this is median glossoepiglottic fold, and this will be lateral, this will be, just a minute, this will be lateral glossoepiglottic fold. So the space which is lying, can you see the cross mark area? The space which is lying between the medial and lateral glossoepiglottic fold, that space is called as vallecula. So Ashif, have you understood? Asif. So this space is called as vallecula. So we know that epiglottis is attached to the posterior part of the tongue by folds. What is the name of that fold? In the midline, that fold is called median glossoepiglottic fold. In the lateral aspect, it is called as lateral glossoepiglottic fold. So, in between medial and lateral glossoepiglottic fold, there is a space that is marked by a cross, and that space is called as vallecula. Clear now? Okay, Asif. Okay. Now, in the inferior aspect of the tongue, we have got the location of deep lingual vein. We have got another fibrous area here. You can see the inferior part is connected to the inferior part of the tongue is connected to the oral cavity inferiorly by a attachment of mucosal fold that is called as frenulum linguae, and also there is a fimbricated fold laterally. Okay. Yes, good evening Mahendra, good evening. So, actually there is also opening of the orifices of submandibular duct which is called as Wharton's duct. So, that means in the inferior aspect we have got following things. We have got frenulum linguae, we have got deep lingual vein, we have got pilica fimbricata, and also the opening of submandibular duct. Submandibular duct is also called as Wharton's duct. Is also called as Wharton's duct. It is also called as Wharton's duct. So, done with this? Okay. Now, I would like to talk about the muscles of the tongue. So, actually the tongue mass, if I talk about the tongue mass, it itself is made of intrinsic group of the muscles, and that intrinsic group of muscles are the superior longitudinal, inferior longitudinal, verticalis, transverse group of muscle fibers. They are forming the intrinsic muscles of the tongue. But tongue is attached to the neighboring structure that is called as extrinsic group of muscles, and the name of that extrinsic group of muscles are, it is having genioglossus, hyoglossus, stylo, and chondroglossus. Actually, chondroglossus is the muscle which is derived from the hyoglossus only. So, we have to know about this 5 muscles of the tongue which is called as the extrinsic muscles of the tongue. So, in this diagram we can see the muscles. We can see the genioglossus muscle, we can see the hyoglossus muscle, styloglossus muscle, the palatoglossus muscle, and also we know that chondroglossus muscle is the part of hyoglossus muscle one. So, one by one I will talk about all the extrinsic group of muscle. The first, fan shaped muscle, which is appreciated in this image. Can you see this fan shaped muscle appreciated in this image? So, this muscle is hyoglossus. Exactly, sorry, this muscle is genioglossus. Please correct it. This is genioglossus muscle. So, this fan shaped muscle which you are seeing here is the genioglossus muscle, and it is attached to the genial tubercles of the mandible, and it is fanning out as you can see in the image, and let it get attached to the lateral aspect of the tongue as shown in this image. This muscle is called as genioglossus muscle. So, the bulk of the muscle, if I talk about the bulk of extrinsic muscle which is formed, the bulk of extrinsic muscle is formed by genioglossus muscle. It arises from the mental spine, and also it is attached to the tubercles, to the genial tubercles, and it is merging with the that of the lateral aspect of the tongue, and a very important function is attached. Actually, in the previous year of examination, this has been asked as an entrance question for the NEET PG exam, and also for the FMG exam, which is the safety muscle of the tongue. The answer is the genioglossus muscle is considered to be the safety muscle of the tongue. And the reason why it is considered to be the safety muscle of the tongue is because among all the extrinsic muscles of the tongue, this is the only one muscle which is protruding the tongue outside. So, it is able to protrude. It is not letting the tongue to roll back. It protrudes the tongue, and that is the reason it is regarded as the safety muscle of the tongue. When acting together, the genioglossus muscle can depress the center part, but one of the important action is it protrudes the tongue, and so its important action is protrusion of the tongue, so it is called as the safety muscle of the tongue. It is called as the safety muscle of the tongue. Now let's talk about the other muscle which is quadrangular in shape. So I just want to actually here we what I have highlighted in this image is the quadrilateral or quadrangular muscle. This I am using H for it. This is the hyoglossus muscle. Lower down you can see it is attached to the hyoid bone, and also in the upper aspect it is again merging with the sides of the tongue. So actually hyoglossus muscle is the quadrilateral muscle, and it is actually arising from the hyoid bone, greater corona of the hyoid bone, and it passes vertically upward and it get inserted into the sides of the tongue, exactly between the styloglossus muscle and the inferior longitudinal muscle of the tongue. Inferior longitudinal muscle of the tongue is the intrinsic muscle of the tongue. Styloglossus is one of the extrinsic muscles of the tongue. The important point about hyoglossus muscle is that it is forming the floor of submandibular triangle, which we have already completed in the previous part. Hyoglossus muscle important function is it depresses the tongue, that is most important, retracts the tongue and make the dorsum of the tongue convex. So basically it is making the dorsum of the tongue convex. It is making the dorsum of tongue convex. But retraction of the tongue is a primary action of styloglossus muscle. So please don't get confused. It is an additional action together making the dorsum of the tongue convex, and it is depressing the tongue. But agar retraction of the tongue term comes or it comes for examination, you have to mark styloglossus as the right answer. The next is the styloglossus muscle. If I talk about the styloglossus muscle, it arises from the anterior lateral aspect. The word, so here I just want you to show this muscle. This is exactly the styloglossus muscle. This is the styloid process. What is this? This is the styloid process. And exactly on the styloid process, the muscle which is attached is styloglossus muscle. Which muscle is this? This is the styloglossus muscle. This is the styloglossus muscle. So styloglossus muscle is attached to the styloid process, merging with the lateral aspect of the tongue, and it will actually it has got a very important function. It is creating a trough for swallowing the food, and it is important function is retraction of the tongue. So whenever the question comes about the retraction of the tongue, the muscle which is retracting the tongue, we will go with the styloglossus as the right answer. Now the next muscle is palatoglossus muscle. The next muscle is palatoglossus muscle. So if I talk about the palatoglossus muscle, which has been highlighted in this image, it is arising from the palatine aponeurosis. Okay. So this is arising from palatine aponeurosis, and this has got a very important function. Actually, this is also inserting into the sides of the tongue, and a very important function attached to the palatoglossus muscle. It is the odd man out muscle because its innervation is also not about tongue paralysis. Okay, Vrushali will come to that. Yes, definitely I will come to the paralysis of the tongue. Now, it is having an action of elevating the posterior part of the tongue, and it is actually not letting the food particles to go inside the airway cavity. So, it is approximating the palatoglossal arch. What is the exact function of palatoglossus muscle? It is approximating the palatoglossal arch. The next is the, so one more muscle is there, that is called as chondroglossus. To be more specific, in some of the book it is written, and it is a muscle of a part of hyoglossus muscle only. It's a part of hyoglossus muscle only. So please don't get confused, because many books has not mentioned about chondroglossus muscle, but it's a part of hyoglossus muscle. It arises from the medial aspect of lesser corona, and it is continuous with the body of hyoid bone. If I talk about its action is actually it is merging with the in between hyoglossus and genioglossus muscle, has got an action similar to that of adding the action of hyoglossus muscle. Now let's talk about, yes, Ajan, you are absolutely right. The odd man out is the palatoglossus muscle. All the muscles of the tongue is supplied by hypoglossal nerve except the palatoglossus muscle, which is supplied by vagus nerve, which is carrying the part of cranial part of accessory nerve. So yes, Azan, you are absolutely right. Yes, Azan, you are absolutely right. So I will just like to cover up this tongue, and then we will have an MCQ session regarding this. The intrinsic muscles of the tongue is superior longitudinal, inferior longitudinal, transverse and verticalis, and all these muscle has an action of changing the shape of tongue. So they are changing the shape of the tongue. So if I talk about superior longitudinal, they inferior longitudinal, transverse, vertical, all of this has got an action of just changing the shape of the tongue. Now let's talk about the arterial supply and the venous drainage of tongue. Very, very important for you to note down. So actually arterial supply of the tongue is that it is having the, so if I just enlarge this image, you can see in this image, it is an image taken from the Gray's Anatomy, and you can see that it is having arterial supply from the source of branches of lingual artery, also from the tonsillar branch of the facial artery and ascending pharyngeal artery. The venous drainage is also important, and the veins draining are deep lingual vein, the dorsal lingual vein, and the vena commitans. What do you mean by the vena commitans? The small veins which is surrounding nerves or artery, they together forms the vena commitans. So we have got small veins surrounding hypoglossal nerve and small veins surrounding lingual artery. These are the veins draining in the tongue. So we will write about the arterial supply and we will write about the venous drainage. So please write down arterial supply of the tongue. Arterial supply of tongue. So the arterial supply of tongue. So we have got the arterial supply from following sources. So the important arteries which is giving blood supply and nutrition to the tongue is the branches of lingual artery. It is via branches of lingual artery. It is via tonsillar branches of tonsillar branches of facial artery. It is via ascending pharyngeal artery. So actually these are the three sources of arterial supply to the tongue, that is branches from the lingual artery, we have got branches from the tonsillar branch of facial artery, ascending pharyngeal artery. Now talking about the venous drainage, so when I talk about the venous drainage, the important veins draining are, so we have got an important veins which is draining the tongue. So let's just write on the name. The veins are deep lingual vein. This is the deep lingual vein. Actually deep lingual vein is the principal vein of the tongue, and the other veins, actually if we talk about deep lingual vein and all, there are dorsal lingual vein. Ultimately these all veins will be going and draining into facial vein and that of internal jugular vein. The other is vena commitans. Vena commitans accompanying lingual artery. Then we have got vena commitans accompanying the hypoglossal nerve. So it is accompanying the hypoglossal nerve. So actually these are all the venous drainage, and ultimately as I told you, these blood from these venous drainage will ultimately go to the facial vein, and ultimately it will drain into the internal jugular vein. Now talking about the innervation of the tongue, innervation of the tongue is highly important. So I just want everybody to concentrate on this topic, because one or two question is absolutely coming from this topic. So exactly you have to know about the innervation. So firstly I am going to explain the innervation by taking this image. So exactly if you will enlarge this image, you can see on one side the red color, pink color has been used, and actually all the muscles of the tongue. All the muscles of the tongue is supplied by which nerve? The answer is hypoglossal nerve, except the odd man out, that is palatoglossus muscle. Palatoglossus muscle is supplied not by the hypoglossal nerve, but it is supplied by the vagus nerve, and the vagus nerve is carrying the fibers of cranial part of accessory nerve. It is carrying the fibers of cranial part of accessory nerve and giving innervation to it. Now talking about, so one side we have got a motor innervation and the other side we have got a sensory innervation. Okay, Vrish. Okay, dear. Okay, so actually many Vrishali will come to the clinical aspect. Don't worry. Actually, I just removed that part from the tongue because I thought that it will become a very big session, because important topics of head and neck to be overcoming with the examination is also important. But yes, I will give you like some. There is Candida albicans in case of tongue. There is a thickening of the tongue. There is hairy plaque tongue. There is a also a tongue ulceration is there. So all these things in the different kind of fungal infection of the tongue affected, hypertrophy of the lingual of the papillae lingual, all these happens. And one of the most important anatomical fact about the tongue which is going to be asked is the paralysis of the muscles and the injury of hypoglossal nerve. Now if I talk about the motor supply, all the muscle is supplied by hypoglossal nerve except the platoglossus muscle which is supplied by the vagus nerve. Sensory supply is that we will divide the sensory innervation into anterior part. So when I am talking about anterior, so this is the anterior two-third part of the tongue. So in the anterior two-third part of the tongue, the general sensory innervation is via lingual nerve and special taste sensation is via coda tympanic nerve. If we talk about the posterior part of the tongue, and we include also the circumvallate papilla. In this condition, we are also including the circumvallate papilla. This is via glossopharyngeal nerve and that of glossopharyngeal nerve, which is giving sensory innervation to general sensation and taste sensation, and the posterior most part of the tongue is getting innervation by internal laryngeal nerve. So actually in posterior one-third part of the tongue, both the sensory and taste sensation is via glossopharyngeal nerve. Now please write down. Motor supply. So all the muscles of tongue, all the muscles of the tongue is supplied by, all the muscles of the tongue is supplied by hypoglossal nerve except platoglossus, except platoglossus muscle which is supplied by vagus nerve carrying the fibers of cranial part of accessory, carrying the fibers of cranial part of accessory nerve. Okay. If we talk about sensory supply, so if I talk about sensory supply of the tongue, so if we talk about the sensory supply, anterior two-third part of the tongue, general sensation, general sensation, general sensory sensation. So general sensory sensation means touch, pain and all. So general sensory sensation is via lingual nerve, and we know that lingual nerve is a branch of mandibular nerve and mandibular nerve is a branch of trigeminal nerve. The posterior, now this was about general sensation, but I just want to elaborate about the taste sensation. So if I talk about taste sensation, the taste sensation is via coda tympanic nerve, and this is a branch of facial nerve. The posterior one-third part of the tongue. So not only posterior one-third part, but also the circumvallate papillae, which is also included in this category of posterior one-third. It is having the innervation by glossopharyngeal nerve, the ninth cranial nerve, glossopharyngeal nerve. Actually, glossopharyngeal nerve is giving innervation both sensory, so it is giving innervation both sensory general, both sensory general plus the taste sensation. And if I talk about the posterior most part of the tongue, if we talk about posterior most part of tongue, So posterior most part of the tongue, it is giving innervation. So posterior most part of the tongue, please don't get worried, it will be, I will be seen soon. Okay, don't worry. So posterior most part of the tongue is via vagus nerve branch. Vagus branch. What is it? Internal laryngeal nerve. Internal laryngeal nerve. And I just want everybody to note down that this is also giving both sensory, that is the general plus the taste. General plus the taste. I have written in small GT. Is it okay? That means it is laryngeal nerve, that is both general plus T for the taste. So both general and taste sensation. So actually this is highly important for you to note down the sensory innervation, as here we have to know, because nerve supply of tongue, so many questions has been asked in the previous year of examination. Now I would like to talk about the lymphatic drainage. So let's talk about the lymphatic drainage. If I talk about the lymphatic drainage, we have to know about the drainage, because carcinomas of the cancers are metastasizing from one side to other side. So it is important that we should know this. So if I talk about the tip of the tongue, the lymphatic drainage is going to the submental. So tip of the tongue, the lymphatic drainage is going to the submental lymph node. Crossing over of the lymphatic from right and left side is seen. Laterally it goes to submandibular, and also posteriorly in the lateral aspect there, posterior also the crossing over of the fibers are there, lymphatics is there. So actually tip of tongue drains into submental lymph node, right and the left half into submandibular lymph node, and posterior 1/3 is draining to jugulo-omohyoid lymph node. Ultimately it drains into deep cervical lymph node. So actually what you can appreciate in this image, that is the crossing over of the lymphatic drainage of one side to the other side is seen. That means cancers of one side of tongue can metasize to the other side. So that is a clinical aspect related to it. Now the other case is of tongue tie. As I told you that inferior, can you see the image of the baby, and you can see the baby is not able to protrude the entire tongue. In normal cases, see here, I can protrude it. Why? Because you can see this is frenulum linguae. What is it? This is frenulum linguae, and this frenulum linguae, which lies on the inferior part of the tongue, it is the mucosal fold which is more anteriorly connecting to the floor of the mouth, and it is a disorder in which tongue tie or ankylosis is the term used for it. So it is not letting the protrusion of the tongue, and it will be related with the abnormalities of thickened frenulum linguae, speech difficulty, swallowing difficulty, and eating difficulty. So it's very easy to solve the case. Just a nick on the frenulum linguae and the protrusion of tongue can be done. A small surgical procedure has to be done. Now this was very important. Many of the students has asked about hypoglossal nerve injury. Actually the bulk of the muscle forming the tongue is that of the genioglossus muscle. So in case of low motor neuron injury, the tongue will deviate to the same side or ipsilateral side, but in case of upper motor neuron injury, the tongue will deviate to the other side. So actually we know that the bulk of the muscle is genioglossus muscle, and the action of genioglossus muscle is protrusion of the tongue. Okay, so if one side of the tongue is not functioning, so it is not protruding, the other side of genioglossus will protrude, and this will lead to deviation of the tongue to same side. So have you understanding this concept? What will happen if the hypoglossal nerve of one side is injured? If hypoglossal nerve of right side is injured, that means which muscle will be paralyzed? Right genioglossus muscle. And we know that bilateral action, when the contraction of genioglossus muscle occurs, it will protrude the tongue. Now right side is not working, but left side protrusion is occurring. That means same side deviation, ipsilateral deviation of the tongue will be seen in case of hypoglossal nerve injury, which is more common lower motor neuron injury. So exactly the question is talking about a burning sensation. The patient is experiencing a burning sensation. As you can see here, the patient is experiencing a burning sensation at the tip of the tongue, the sensation. So here Hariharan has given the answer trigeminal nerve. What about the others? Hariharan has given his answer and he is telling it's the right answer is trigeminal nerve. What about others? Anyone want to add on something? So actually Hariharan is absolutely right. He is absolutely right and he has given absolutely the right answer. The trigeminal nerve. Actually, the anterior part of the tongue, if we are talking about the sensation which is felt at the tip of tongue, we mean to tell that tip of the tongue general sensation we are talking. So general sensation at the tip of tongue is done by lingual nerve. So, burning sensation is a general sensation, and this is a general sensation in anterior two-third part of the tongue. In anterior two-third part of tongue. And lingual nerve is a branch of mandibular nerve, and mandibular nerve is a branch of trigeminal nerve. So definitely the right answer will be trigeminal nerve. Definitely the right answer will be trigeminal nerve. So a thumbs up goes for Hariharan. Yeah. Now here if I talk about lingual nerve, the lingual nerve is a branch of mandibular division of trigeminal nerve. It's a branch of mandibular division of trigeminal nerve, and it is giving sensation. So we know that burning sensation is a general sensation. If it was about the taste, then it was a coda tympanic nerve in the anterior two-third part of the tongue. Coda tympanic is not the right answer because it is giving taste sensation in the anterior part. Glossopharyngeal nerve is not the right answer because it is giving general sensation and the taste sensation both. Hypoglossal nerve is not the right answer because it is importantly giving the innervation to the muscles of the tongue. Vagus nerve is also not the right answer because it is giving both general sensation and taste sensation in the posterior most part of the tongue via its branch internal laryngeal nerve. So I would like to go for a second question. So let me slightly enlarge it. So all of you please read the second question and give me the right answer. A 35-year-old male comes to your office complaining of a painful tongue sore. He also complains that over last 2 weeks he has a fever and has been experiencing myalgia and arthralgia. He has no other medical problems. The patient works as a driver for a local delivery service. He is homosexual and he admits of having unprotected sex with a stranger approximately 1 month ago. Physical examination reveals rash over his trunk and cervical lymphadenopathy. Any ulcer is located on the median sulcus of the tongue 1 cm anterior to foramen cecum. You decide to draw a blood for the HIV viral load and describes oral analgesic to relieve the ulcer related pain. The sensation from the ulcer is carried by which of the following nerves? So actually basically most important point is the location of ulcer. The location of ulcer is in the median sulcus 1 cm anterior to foramen cecum. The pain sensation is carried by which of the following nerve? That is the right answer. So again your time starts now. You can give me the right answer. So just go through this. I will give you 30 seconds to mark the right answer. So I would like to give you 30 seconds to mark the right answer. So actually the location, please pay attention to the location. If I talk about the location of the ulcer, it is lying anterior to the foramen cecum. It is lying anterior to foramen cecum, and definitely if it is lying anterior to foramen cecum, it is located in anterior part of the tongue. And as I told you, anterior part of the tongue general sensation is lingual nerve. So anterior to foramen cecum is the anterior to foramen cecum. The location is of ulcer, which is located in the anterior two-third part of the tongue, and the sensation is pain. So pain is a general sensation. Pain will be a general sensation, and definitely the general sensation in the anterior part is via lingual nerve, and we know that lingual nerve is a branch of mandibular nerve. So definitely the right answer is C. So Nitin, you get a thumbs up. You are absolutely right. You are absolutely right. The right answer is mandibular nerve. So I just want you to show this image. Here what happens, this is sulcus terminalis. This is sulcus terminalis, and posteriorly there is a foramen cecum. So exactly that means it is which part of the tongue? It is anterior part of the tongue, and posterior to foramen cecum is the posterior part of the tongue. Now as we know, the anterior part of the tongue general sensation is via lingual nerve. So definitely the right answer, lingual nerve, will be a branch. So definitely the lingual nerve is a branch from foramen. It's a branch from mandibular division of trigeminal nerve. Posterior 1/3 of the part of the tongue will have both general sensation and that of taste sensation carried by the carried by, if I talk about posterior 1/3 part of the tongue, both general sensation and taste sensation is carried by the glossopharyngeal nerve. So definitely the ulcer location is anterior to foramen cecum, so it comes in the anterior part, so lingual nerve is the right answer. So lingual nerve is the right answer. So let's talk about the orbit. So in this diagram, I want you to show the orbit or the cavity or the socket of the skull in which different colors of the bone. So to know the exactly what all structures are forming the boundary, it is important to use different colors. So you can see the important surrounding bones of the orbit. So we have got this yellow color for the frontal, we have got green color for the lacrimal bone. So this is the lacrimal bone. So actually I am not writing it, it's already written. So we have got surrounding bones like lacrimal, frontal, zygomatic, maxillary. We have got palatine bone, sphenoidal bone. Also the part of the nasal bone is illustrated, but that is not forming the part of boundary of the orbit. So it is important that we should know all the structures which is forming the boundary. And now next is to know about the content. So the important contents of the orbit is following: eye, orbital, retrobulbar fascia, cranial nerves, that is second, third, fourth and fifth, sixth, blood vessel, fat, ciliary ganglion, short ciliary nerves, lacrimal gland and nasolacrimal duct. So all these structures which has been mentioned here, all these structures are the content of orbit. All these structures are the content of the orbit, and you have to know the details of the content of the orbit. And other than that, the most important thing which is very important for your examination is to know about extraocular muscles. So I would like to talk about the 7 voluntary extraocular muscles. So how many voluntary extraocular muscles are there? Together we have got 7 voluntary extraocular muscles. Together we have got 7 extraocular muscles. So exactly we have got 4 recti muscle and we have got 2 oblique and 1 levator palpebral superioris. So we have got 4 recti muscle. So we have got 4 recti muscle. So exactly together we have got the superior rectus muscle, we have got the inferior rectus muscle, the medial rectus and the lateral rectus. So together we have got 4 recti muscle, and we have got the 2 oblique muscle, and we have got LPS muscle, levator palpebral superioris muscle. So together we have got 7 muscles. Okay. So one by one we will talk about it. So exactly all the muscles has been shown. More superiorly is the levator palpebral superioris muscle. The oblique direction yellow color muscle is the superior oblique. We have got inferior oblique and 4 recti muscle. What is important for us is to understand the origin insertion of all these muscles. So what I want everybody to concentrate on this image. So I am just enlarging this image. So exactly in this image you can understand the attachment of these muscles. So we have got here medial rectus muscle, and we have got superior rectus muscle, we have got inferior rectus muscle and lateral rectus muscle. So these are the 4 recti muscle which is originating from. So if I talk about these 4 recti muscle, these are the 4 recti muscle, and these 4 recti muscle is originating from annulus of Jig. So they are so if you will see the superior orbital fissure in the study class I have shown you, in the center there is a ring, that is called as tendinous ring. That ring is called tendinous ring of annulus, so gin of annulus, and from there the 4 recti muscle originates, and these recti muscles are inserting. So if you will see these recti muscle, you can appreciate that these recti muscle are inserting. So exactly these recti muscles, as you can see here, these all muscle are inserting posterior to the sclerocorneal junction. That is, all these recti muscle are inserting posterior to sclerocorneal junction or limbus. As you can see, this black color structure is the cornea, and you can see this is the equator. This is the equator. So if you will see the insertion of these recti muscle, this is one recti, this is one, and this is the other recti muscle. So what you can appreciate, these recti muscle are inserting These all recti muscle are inserting anterior to equator and posterior to sclerocorneal junction. If we see the oblique muscle, this is one oblique muscle, this is other. So we have got inferior oblique and we have got the superior oblique muscle. So if we talk about superior oblique and if we talk about inferior oblique, both the oblique muscle, you will see both the oblique muscles. So what you can appreciate, both these oblique muscles are inserting into posterior superior quadrant of eyeball, posterior to equator and posterior to the limbus. So this is the difference between the insertion of oblique muscle and recti muscle. If we are talking about recti muscle, they are inserting posterior to limbus and anterior to equator, but oblique muscle are inserting posterior to equator and posterior to limbus. So let's write it. Okay, let's write about these muscles. So let's write about these muscles. So I will start with the 4 recti muscle. So if I talk about the 4 recti muscle, we have all the recti muscle. All the recti muscles arises from the corresponding margin of corresponding margins of common tendinous ring. This is about the origin. If I talk about insertion, if we talk about the insertion of all the recti muscle, is inserted into sclera, little posterior to limbus, and in front of equator, posterior to limbus and in front of equator. In front of equator. Got it? Now let's talk about the oblique muscle. So let's talk about the first oblique muscle, that is the superior oblique muscle. Superior oblique muscle. The superior oblique muscle origin from the body of sphenoid. So it is originating from the body of sphenoid supromedial to optic canal, If I talk about insertion, it inserts into the sclera, behind the equator and in posterior superior quadrant of eyeball. So done with this. Now talking about inferior. So actually the one more oblique muscle is there, that is inferior oblique muscle. So let's talk about the inferior oblique muscle. If I talk about inferior oblique muscle, so I just want to write over inferior oblique muscle here itself. So if I talk about inferior oblique muscle, the inferior oblique muscle originates from So exactly, if we will see the origin, this is the one muscle which is originating. So if we talk about the origin, it is originating from the inferior wall. So here inferiorly, this is one muscle which is originating inferiorly from the orbit, and this is exactly originating inferiorly from the orbit. So it is originating from the floor of orbit, lateral to lacrimal groove, lateral to lacrimal. And if I talk about insertion, so the insertion is, it inserts. So if I talk about the insertion, it inserts into the sclera close to the insertion of superior oblique muscle. Close to the insertion of superior oblique muscle. Done? Done here? Done. Now the next thing is to know about so the one more muscle which I want everybody to know is levator palpebral superioris muscle. Any of the student is having any doubt, they can ask me. Let me just check if any of the student is not understanding anything. Okay, so now we are now with the LPS muscle. The next muscle is LPS muscle, levator palpebral superioris muscle. So this is the LPS muscle, as you can see. This is levator palpebral superioris muscle, and this LPS muscle is inserting into the eyelid. Can you see? It is inserting into the upper eyelid. Levator palpebral superioris muscle is the most superior aspect. This is the muscle lying superiorly, inserting into the levator palpebral upper eyelid, and it is important to know the importance. It is important to know about the origin and insertion. So actually, insertion is in the form of lamina. So exactly, if I talk about the levator palpebral superioris muscle, it is originating from exactly it is originating from the sphenoid bone. It is originating from the sphenoid bone, and thereafter what is most important, that it will form three lamina of insertion. It will form three laminas of the insertion. So you can just write LPS muscle originates from sphenoid bone and inserts in the form of three lamina, in the form of three lamellae. The insertion is in the form of three laminas. Actually it is made of both skeletal and smooth muscle. So it is made of both skeletal and smooth muscles. So actually it is made of both skeleton and smooth muscle, and this will insert into the superior tarsal plate of the upper eyelid, also in the conjunctiva. So exactly it will have dual nerve supply. That means LPS muscle, skeletal muscle fibers will have innervation by oculomotor nerve, and smooth muscle will get innervation via sympathetic innervation. So here you can just write LPS muscle is having innervation by both third cranial nerve and sympathetic. So other than that, it is also having sympathetic innervation. It is also having sympathetic innervation. Done with this. Now all the muscles, if I talk about all the extraocular muscles of the eye, it is innervated by, all the extraocular muscles is innervated by third cranial nerve, except LR6 and SO4, So here lateral rectus is innervated by abducer nerve, and that of superior oblique is inserted by, superior oblique is getting innervation from the trochlear nerve. Now extraocular muscles, so let's talk about the extraocular muscles. So we have got following extraocular muscles, and the action of these muscles are occurring in the three planes. So we have got so exactly there is three planes that that elevation and depression is occurring along transverse plane, the adduction abduction along vertical axis movement, and that of the intorsion inward rotation of the eyeball, and extorsion is the word used for the outward rotation of the eyeball. So this is occurring along AP axis. This is occurring along AP axis. So it is important that we should also know the individual. So it's also important that we should know the action of individual muscles. So is it okay, everyone? So you have to know about the action of individual muscles, and already in the image I have shown you that the muscle is having their actions, depression and elevation along transverse axis, abduction and adduction along vertical axis, and that of intorsion and extorsion along the AP axis. So I would like to give you the details of all the muscles action. So let's write it. Write on the heading. Action of extraocular muscles. Okay, action of extraocular muscles will be known to you. So action of extraocular muscles. Action of extraocular muscles. Let's talk about the action of extraocular muscles. So the action of extraocular muscles are following. They are superior rectus. So if I talk about the superior rectus muscle, the superior rectus, so we have got actually oblique muscle will have the action just opposite to its name, but superior rectus muscle, if I talk about superior rectus muscle, its action is it causes elevation, it causes adduction and intorsion. If we talk about inferior rectus muscle, inferior rectus muscle, it is causing depression, adduction and extorsion. We have got medial and lateral rectus. So if I talk about medial rectus muscle, it is causing adduction of eyeball. Lateral rectus is having the action of abduction. So this, other than that, we have got two oblique muscle and their action is just opposite to their name. So we have got superior oblique muscle and we have got an inferior oblique muscle. So as the name is there, superior, inferior, oblique, so the action of these extraocular muscle is just opposite to their name. So if I am talking about the oblique muscle, that is superior oblique muscle, so the superior oblique muscle is having the action of depression, abduction and intorsion. If I talk about inferior oblique, it is causing elevation, abduction and extorsion. And we have got the next muscle, the seventh one, LPS muscle. The LPS muscle is causing elevation of upper eyelid. Done. Now I would like to talk about the fascicle sheath. So we will talk about the fascicle sheath. So if I am talking about the fascicle sheath, it is actually a membranous envelope of the eyeball, and actually let's talk about the attachment of the fascicle sheath. The attachment is anteriorly it is attached to SC junction. What do you mean by SC junction? SC junction means it is attached to sclerocorneal junction. It is attached to sclerocorneal junction. Posteriorly it is merging with the optic nerve, and an important point about the fascicle sheath of the eyeball is that it is merging with the recti muscle and it is merging with the oblique muscle. So the ligaments, other than that, fascicle sheath is merging with the recti oblique muscle laterally, inferiorly, medially, and it will form a check ligament. So it is actually having its attachment. So fascicle sheath of the eyeball when merged laterally, it is attached to Whitney's tubercle, and medially it is attached to posterior lacrimal crest. So medially it is forming medial check ligament, laterally it is forming lateral check ligament. Lateral check ligament is attached to Whitney's tubercle, and medial check ligament is attached to posterior lacrimal crest. What about inferior aspect? So when we talk about inferior aspect, the fascicle sheath is merging with inferior oblique inferior rectus muscle. So inferiorly it forms suspensory ligament. So inferiorly it forms suspensory ligament. So inferior aspect it forms suspensory ligament, and it will give a hammock like support to the inferior aspect, and it will merge with the inferior rectus inferior oblique muscle and give support to the eyeball. So it will give support to the eyeball. It is merging inferiorly and it merges with inferior oblique muscle and that of inferior rectus muscle, and it will give hammock like support inferiorly, forming suspensory ligament of eyeball. Now let's talk about the clinical correlation. So the clinical correlation of oculomotor nerve is lesions of oculomotor nerve will lead. Yeah, so exactly as I told you, all the muscles, extraocular muscles, if I am talking about all extraocular muscles, it is getting innervation from third cranial nerve or oculomotor nerve. We have got certain muscle which is not getting innervated like SO4 and LR6. So that means lateral rectus muscle is not paralyzed and the superior oblique muscle will not be paralyzed, because lateral rectus is getting innervation from abducens nerve and superior oblique is getting innervation from trochlear nerve. So that is the reason, and exactly the affected eye is placed laterally by the lateral rectus muscle because of the action of lateral rectus muscle, and also by superior oblique muscle. So the position of the eye in case of oculomotor nerve injury will be eye is looking down and out. So if you appreciate this, what you can appreciate, the eye is looking down and out. The eye is looking down and out. Okay dear. Now trochlear nerve. If I talk about the trochlear nerve, it's the superior oblique muscle is innervated by trochlear nerve. So that means only one muscle will be injured, that is superior oblique muscle, and the action of just superior oblique muscle is gone. So the patient will not have much of features seen as you see the eye, but you can see diplopia, and also the patient may develop head tilt away from the site of lesion. So the patient will have all the other muscles are intact, only diplopia is the feature which is seen, and the position of eye is not affected much, but there is actually no obvious sign seen when the resting orientation of the eyeball is there. It will seen when a sideway head tilt is done, then we can see the trochlear nerve injury palsy. The other is abducens nerve. If I talk about the abducens nerve, if any of the student is having any doubt, let me know. Okay. So actually, if I talk about abducens nerve, that is lateral rectus muscle, is the only one muscle which is getting innervation from the sixth cranial nerve, and the action of lateral rectus muscle is abduction, that is lateral movement, abduction. So exactly the patient will develop medial squint because of the action of medial rectus muscle. So the eyeball is moved medially and the patient will have medial squint because of the action of medial rectus muscle. Now I would also like to talk about Horner syndrome. Actually, Horner syndrome is a triad of symptom which is produced by sympathetic trunk. So exactly when I talk about Horner syndrome, what happens? The sympathetic fibers innervating the LPS muscle will be involved, but oculomotor nerve is not injured. Actually, this is conceptual. Please try to understand. Actually, for the whole paralysis or a complete paralysis of LPS muscle, levator palpebral superioris, both the oculomotor nerve and that of the both oculomotor nerve and that of sympathetic innervation has to be gone. So that means LPS muscle will be not fully paralyzed. Okay. So in sympathetic innervation is gone, that means the smooth muscle fibers of LPS muscle is not working. At the skeleton muscle fibers are working. What will happen? This will lead to a case of partial ptosis, and the patient will have constriction of pupil, that is called as pupillary constriction will be appreciated because of denervation of due to the denervation of dilator pupillary muscle. Anhidrosis will also be seen in the case of Horner syndrome. Now, can we solve an MCQ related to this? Everyone, can we solve an MCQ related to this topic? Everyone? Can we have a discussion of one MCQ related to this topic? Okay. So, let's solve. I will give you a few seconds. Okay, Nitin. Okay. Okay, dear. A 30-year-old male presents to the emergency room after being involved in a street fight. There is significant soft tissue swelling around the left eye. The imaging study reveals orbital floor fracture with accumulation of fluid. So, accumulation of fluid is there. So, actually, can you tell me which of the following structure is involved in this case? Ethmoidal sinus, maxillary sinus, frontal sinus, sphenoidal sinus, or inferior concha? So, mark the right answer, dear. So, I got an answer C from Nitin. Frontal sinus. Okay. So, I will give you a hint. Left orbital floor is fractured. Orbit floor is fractured here. Orbit floor is fractured. See, floor will involve which structure? Okay, Nitin. And I just want to enlarge this image. Now, tell me the right answer. CA. What about others? Can you tell me the fracture is of which? So, I am just enlarging it. See, fracture is in the floor. Now, give me the right answer. Please mark the right answer. So, Rashmi is telling, Rashmi Burria is also telling A. So, A, C. Anyone else? Multiple answers are coming up. Anyone wants to give the right answer? The correct answer is maxillary sinus. The correct answer will be maxillary sinus. So, you can see generally the sinuses contains air. So, it is black in appearance. Floor, if we talk about the floor, here we have what maxillary sinus. So, in this case, maxillary sinus will be fractured. So, in this case, maxillary sinus will be fractured. So, you can see here the orbit is bounded superiorly by orbital plate of frontal bone, laterally by the zygomatic greater lesser wings. Orbital floor is formed by the maxillary sinus. So, you can see here orbital floor is formed by maxillary sinus. So, that means here actually floor and medial wall, that is medial wall is formed by lacrimal and ethmoidal bones. Ethmoidal air sinuses is there. So, that means floor and that of medially you will see the ethmoidal air sinuses and lacrimal bone, that is more fractured in this case. So, here once again I want you to show this orbital image orbit, and you can clearly see the here you can clearly see this we have got this as a maxillary bone, maxillary sinus and maxillary air bone. So, definitely maxillary sinus is ruptured in this case or fractured. So, here in this case the blunt trauma is to the eyes is increasing the pressure and fracture is at the floor. The floor, and as you can see there is air. So, if you can see one side there is air, so it appears. So, there is air, but other side the fluid is accumulated in the maxillary sinus. So, exactly the maxillary sinus has been not opaque now. It as a maxillary sinus is not containing air now. It is having fluid accumulation. So, definitely that is the right answer. Ethmoidal air sinuses will be lying medially. As you can see, if we talk about ethmoidal air sinus, it will be lying more medially. It is not lying in the floor. You can see in this image. So, this is not the right answer. Same goes with the frontal air sinus. It will rise superiorly. It will lie superiorly. And sphenoidal ear sinus is more located on the posterior aspect. So sphenoidal sinus will be more posteriorly located, as you can see here. And if I talk about inferior nasal concha, it's a separate bone in the lateral wall of the nose. So it is in the lateral wall of the nose. So most important bone to be fractured here is the maxillary ear sinus. Deep cervical fascia of the neck is clinically very important, and we know that entire neck is having a collar like covering. That collar like covering is called, if I talk about entire neck, there it's having a collar like covering, that is called as deep cervical fascia. From outside to inside, the deep cervical fascia is formed by following layers. It is having investing layer of deep cervical fascia, it is having pre-tracheal layer, pre-vertebral layer, and the carotid sheath. So we have in this topic, I am going into the details of, I will explain you about the details of investing layer of deep cervical fascia, the pre-tracheal, the pre-vertebral, and that of the carotid sheath. The investing layer of deep cervical fascia, the investing layer of deep cervical fascia. Then we have got the pre-tracheal layer of deep cervical fascia. The inner is the pre-vertebral layer of deep cervical fascia. Now it's important to know the detail of these all layers. So I would like, so exactly this is an image where you can see the layers, as you can see the area is surrounded, the whole neck is surrounded by the investing layer of deep cervical fascia. And overall here I just want you to tell about the attachment of investing layer of deep cervical fascia. So if I talk about the attachment of investing layer of deep cervical fascia, you can understand that important structure. So superiorly it is attached to external occipital protuberance. So just a minute. So this is the superior attachment, that is it is superiorly attached on external occipital protuberance and that of superior nuchal line. And if I talk about its inferior attachment, inferiorly it is attached to the spine of the scapula. So inferiorly it is attached to the spine of scapula, as you can see here. Inferiorly, if you will see, it is attached to the spine of scapula and acromial process. Anteriorly, if you will see, both the side investing layer will merge in the midline. So you can see in the mid line of neck, in the midline of the neck, the both the side of the investing layer of deep cervical fascia is meeting in the anterior aspect. And posteriorly it is attached to, so ligamentum nuchae is there, this is giving posterior attachment to that of deep cervical fascia, and it is including all important structures. So it is so this is about the attachment which has been shown. So this image is showing you the attachment of deep cervical fascia. So write down attachments of deep cervical fascia. Attachment of deep cervical fascia. Superiorly it is attached to external occipital protuberance, superior nuchal line, to mastoid process and lower border of mandible. Inferiorly it is attached to the spine of scapula, ac- acromion process, upper aspect of clavicle, jugular notch, anteriorly it is attached to the midline of neck. Actually, midline neck means that is starting from the symphysis menti continuous lower down to the suprasternal notch. Ligamentum nuchae and spine of 7 cervical vertebra. So done with this. That means you can just practice on your own body and you can see that superiorly it is attached to external occipital protrusion, superior nuchal line, mastoid process, lower aspect of the mandible, anteriorly in the mid-neck line, then posteriorly going to the ligamentum nuchae spine, and then it comes to the clavicle spine acromial process, and it also merges with the spine of 7 cervical vertebra. This is whole of the attachment. And here you can see this is the investing layer of deep cervical fascia, which is superiorly attached to external occipital protuberance, nuchal line. And in the anterior aspect, it is attached to the mandible bone, hyoid bone, and lower down it is going till the level of manubrium sterni. So actually there are two. So this is showing you the longitudinal. This is showing you the sagittal section or longitudinal tracing of the. This diagram is showing you longitudinal, or you can say vertical tracing of. So exactly, so it is actually a diagram where longitudinal or vertical tracing of deep cervical fascia can be appreciated. And we can see the attachment of investing layer of deep cervical fascia posteriorly and anteriorly in this image. There is one more image. This is also showing the vertical tracing of deep cervical fascia. So it is attached superiorly. It is attached to external occipital protuberance. On the superior aspect, it is attached to external occipital protuberance. It merges with the ligamentum nuchae, and lower down it is attached to the spine of C7 cervical vertebra. So lower down it attached to the spine of C7 cervical vertebra, and on the anterior aspect it is attached to the hyoid bone. It merges with the thyroid cartilage and a cricoid cartilage. This is the investing layer, and lower down it is merging till the level of manubrium sterni. So it will go till the level of manubrium sterni. This is the whole attachment of investing layer of deep cervical fascia. Now I just want to tell about few important points about other than that. So we have done with the attachment and shown in this diagram, but actually there is a horizontal section where you can so this is showing you the horizontal disposition of deep cervical fascia. So here you can see this is the investing layer of deep cervical fascia. It starts from posteriorly from the ligamentum nuchae. It encloses trapezius muscle. In the posterior aspect, it encloses sternocleidomastoid muscle. In the anterior aspect, as you can see, it is forming the roof of, so exactly it is forming the roof of two triangular. So it is forming the roof of two triangles, anterior and posterior triangle. It is enclosing two muscles, sternocleidomastoid and that of trapezius muscle. And when you trace the investing layer of deep cervical fascia, from the level of hyoid bone, it will go on the upper aspect, and it will enclose two glands also. So I just want to show you. So can you see, when the investing layer is traced above the hyoid bone. So when it is traced above the hyoid bone, it is again forming as it is covering the superficial fascia of the parotid gland, forming superficial parietal fascia. And when you see the deeper layer, it is merging with the tympanic plate. It is merging with the tympanic plate, forming stylomandibular ligament. And this will form the stylomandibular ligament will separate two important glands, the parotid gland and submandibular gland. Other than that, when you see with the lower down, so you can see at the lower aspect the investing layer of deep cervical fascia. In the lower down, it is attached to clavicle, and it encloses supraclavicular space. It encloses supraclavicular space. So actually it will be merging with the clavicle superior aspect. So here it encloses supraclavicular space. So exactly it encloses supraclavicular space, and it encloses one more. So it is also having it encloses supraclavicular space, and it encloses another space that is called a suprasternal space and suprasternal space. So actually what happens when you trace the investing layer of deep cervical fascia lower down in the clavicle and above the sternal notch, it is enclosing two spaces, suprasternal space and supraclavicular space. So that is also important for you to note down. So I will talk about all these spaces and important structures related with that of the investing layer of deep cervical fascia. So I just want, if any of the student is having any doubt, please let me know. Ma'am, ma'am, zero question from anatomy NEET PG today. No, it's not like that. Don't worry. There are many questions. So without, okay, here Rashmi is telling no question from. So exactly with no, with there are many questions. There are, so exactly there are two sessions for the NEET PG exam. One is morning and evening session. So if I talk about anatomy questions, it's we have got so many questions which will be asked from the anatomy. Actually, if it is a question of gynae ops, it's a question of surgery. If it is a question of medicine, ENT, all basic part is related to anatomy. So if you are not knowing the basic subject, you are not able to solve the MCQs. So sometimes what happens, you feel that the question is not from the anatomy, but if you are not knowing the anatomy, you can't solve the clinical aspect. So it can't be like that, that no questions is from anatomy. It can't be like that. In 19 subject, if you are not knowing anatomy, if you are not knowing muscles, if you are not knowing nerves, if you are not knowing vessels, how can you proceed surgically? Okay, how can you know that this muscle is levator ani muscle, this muscle is sternocleidomastoid muscle? What is the boundary? What is the extent? What is the innervation? What are the nerve loops? Everything is related here. It's a very core subject here, and it is related with all 19 subjects. So literally, if you are paying attention to this subject, if you are giving your heart to this subject, and try to understand, seeing multiple of images from the good standard books and all, you are definitely going to solve all the question being asked in the NEET PG exam also. So that is very important. Okay, Rashmi, so let's start. So above hyoid bone, above hyoid bone, investing layer of deep cervical fascia. So above hyoid bone, investing layer of deep cervical fascia encloses, above hyoid bone, investing layer of deep cervical fascia encloses parietal gland, submandibular gland, and form stylomandibular ligament. Now, when traced downward, the fascia splits to enclose. The fascia splits to the fascia splits. The fascia splits. That is the investing layer of deep cervical fascia splits to enclose. Two spaces. Okay. So it splits to enclose two spaces. One by one, I will talk about that spaces. So please write down here the two spaces are. Please write down. One of the space is. So that space is suprasternal space. That is above the manubrium sterni. There is suprasternal space of Burns. It is also called as suprasternal space of Burns, and you have to know what all structures lies in the suprasternal space of Burns. So it encloses sternal head of sternocleidomastoid muscle. It encloses jugular venous arch. It encloses interclavicular ligament. And it encloses the lymph node. Other than that, as I told you, it is also enclosing one more space. So exactly, it also encloses, so two spaces it encloses. One is suprasternal space, that is the space above the manubrium sterni. The other space is in the above the clavicle. So here you can write the other space is supraclavicular space. So in supraclavicular space, the investing layer of deep cervical fascia is including following. That is the supraclavicular space. It encloses following important structures, and that structures are terminal part of external jugular vein. It encloses terminal part of EJV, external jugular vein, and it encloses supraclavicular nerve. Supraclavicular nerve. Done with this. Now we have to also know about the rule of two. Rashmi, ma'am, tell us about NEET MDS question also. Okay, dear. Okay. Okay, C is okay. Vivek is telling zero in anatomy how to start. Okay, Vivek Sharma. Yeah, I will tell you. So you have to start. That means you have to start anatomy from beginning. That means you want to start anatomy from the beginning. So you have to firstly go with general anatomical aspect, then study the gross anatomy, correlate with the general embryology and histology part. So okay, NEET MDS actually we have got NEET MDS and questions being solved. They are more related to the head and neck part and few neuroanatomy part. So that is how we will have a NEET MDS session also. Don't worry about that. I will be coming with the NEET MDS papers and sessions discussion. So we will definitely have that session. I just want everybody to note the rule of two. So in deep cervical fascia, there is rule of two. So here I just want everybody, please write down. Rule of two for rule of two. So when I am using the word rule of two, it means rule of two is for the structures being enclosed. So rule of two for the enclosure. Rule of two is for the structure being enclosed by investing layer of deep cervical fascia. Investing layer, structure enclosed by investing layer of deep cervical fascia. So actually investing layer of deep cervical fascia encloses many important structures, and there is rule of two for all the structures being enclosed. So we have to know about that. So please write down all important structures being enclosed. So please write down. It encloses two muscles. Encloses roof of two triangle. Anterior and posterior triangle. Encloses two spaces, supraclavicular and suprasternal space. Supraclavicular and suprasternal space. Encloses two glands. Parotid gland, it encloses the parotid gland and that of submandibular gland. Encloses or split to enclose two space, which we have done, forms the sling of two muscles. Forms sling for two muscles. So exactly, it forms a sling for the two muscle, and the two muscle pulley slings are, it forms a sling for omohyoid muscle, it forms a sling for intermediate tendon of digastric muscle. So it forms a sling for omohyoid muscle and it forms a sling for intermediate tendon of digastric muscle. So done with this. Actually, it also if we are talking about the three layers of deep cervical fascia, that is investing layer of deep cervical fascia, the pre-tracheal and pre-vertebral layer. So actually, if I talk about pre-tracheal and pre-vertebral layer, these are derived from the investing layer of deep cervical fascia. So forms two fascia, that is pre-tracheal fascia and pre-vertebral fascia. So done with this. Now I want to tell about the next layer, that is the pre-tracheal layer of deep cervical fascia. So all of you, so exactly, yeah, I can understand all of you are waiting for the NEET PG exam questions to be solved. So let the exam be over. So today evening or night the exam is over. So tomorrow we will collect as many as the questions asked for the NEET PG exam and we will solve it. So the next layer which you should understand is the pre-tracheal layer of deep cervical fascia. Pre-tracheal fascia. Pre-tracheal fascia of deep cervical fascia. So pre-tracheal fascia or pre-tracheal layer of deep cervical fascia. So actually this layer of deep cervical fascia is covering the sides and in front of the trachea. So hence the name is pre-tracheal fascia. It splits to enclose the thyroid gland. As you can see, it is splitting to enclose the thyroid gland. Above it is attached to hyoid bone and lower, if you will see the inferior limit of the pre-tracheal fascia, it is merging with the fibrous pericardium of the heart. So it is merging with the fibrous pericardium of the heart. Actually, it encloses the thyroid gland and forms a false capsule for it, and it is attached to oblique line of thyroid cartilage. It is attached to the oblique line of thyroid cartilage, and actually It's very important for you to note down that it is then attached to the cricoid cartilage, and it forms the ligament of Berry. So exactly the thyroid swelling is, if you will see a swelling, the doctor, when you come to the, any patient comes to the OPD or for the ward, the doctor asks he or she to move, check whether the swelling is moving with the deglutination or not. So the reason is the formation of ligament of Berry. And also if we see the extent horizontally, it is actually emerging from the, so horizontally you can see it is emerging from the investing layer of deep cervical fascia, and it is actually merging with the forming the anterior wall of carotid sheath. If you will see the vertical tracing, above it is attached to the hyoid bone and below it is attached to the fibrous pericardium. So I just want to show one more image here. So in this diagram, the outermost layer which we have just seen, so this is the investing layer of deep cervical fascia. So this is exactly the investing layer of deep cervical fascia which we are talking about. Okay, now from the investing layer, so we have seen that investing layer is enclosing the sternocleidomastoid muscle, it is enclosing the trapezius muscle as shown in the diagram. And other than that, if I just slightly enlarge it, I can also appreciate here, and I want everybody to know that let's talk about another layer. So we are talking about the pre-tracheal layer. So if I talk about the pre-tracheal layer, it is forming the anterior, it is arising from investing layer, forming the anterior wall of carotid sheath, and it is covering the entire thyroid gland as shown in the diagram. And it is also lying to anterior to the trachea, as you can see. Here in the diagram only I am using a different color for the pre-vertebral layer, which is arising from the posterior aspect of the investing layer, and it is actually covering the all of the this is the pre-vertebral layer covering the back muscles, scalenus group of muscle, levator, scapulae and all, and it is forming the posterior wall or sheath of the carotid. It is, if we talk about carotid sheath, it's anterior. So this is the carotid sheath. And if I talk about carotid sheath, its anterior wall is formed by pre-tracheal layer, its posterior wall is formed by the pre-vertebral layer. So we have got this as the pre-vertebral layer. Now, this was about transverse. Now we will see about the vertical tracing. So we have already done about the investing layer. Now now we will talk about the pre-tracheal fascia. Here in the pre-tracheal fascia, you can see it is attached with the hyoid bone, thyroid cartilage, cricoid cartilage, forming the ligament of Berry, merging with the isthmus of the gland, and lower down, as you can see, it is merging with the fibrous pericardium of the heart. Now if you will see the another layer, that is the pre-vertebral layer, you can see it is attaching to the base of the skull, and lower down it is merging with the longitudinal ligaments. So it is merging with the longitudinal ligaments and going till the level of T3, T4 vertebrae, as you can see here. So here also you can see the investing layer. We have already talked which investing layer we have already talked, and we have seen that investing layer is merging above with the hyoid bone, below it is merging with the manubrium sterni. When we are talking about pre-tracheal layer, you can see above it is attached to the hyoid bone, cricoid, thyroid cartilages. Lower down it merges with fibrous pericardium. When we are talking about pre-vertebral layer, you can say above it is merging with the base of the skull. Lower down it is merging with the anterior longitudinal ligament of T3 and T4 thoracic vertebra. So done with this. Now I just want to go with the pre-tracheal fascia. Pre-tracheal fascia. Pre-tracheal fascia lies, please note down, pre-tracheal fascia lies pre-tracheal fascia lies anterior to trachea. It lies anterior to trachea and encloses the thyroid gland. It encloses the thyroid gland, forming false capsule, attached to oblique line of thyroid cartilage, attached to oblique line of it is attached to the oblique line of thyroid cartilage. From there to it is attached to the cricoid cartilage and will lead to the formation of berry ligament. Now, and if I talk about the vertical extent, so if you want to know about the vertical extent, so you can just write on vertical tracing of pre-tracheal fascia. So it's important to know the vertical tracing. So if I talk about the vertical tracing of pre-tracheal fascia, when traced above, it is attached to hyoid bone. It is attached to hyoid bone, and when traced below, it blends with the apex of fibrous pericardium. It blends with the apex of fibrous pericardium of the heart. It blends with the fibrous pericardium of the heart. Now, if we talk about the pre-vertebral fascia, the next layer is the pre-vertebral fascia. Actually, pre-vertebral fascia, the deepest layer, it's very important to know about the pre-vertebral layer. So, exactly if we talk about the pre-vertebral layer, you can see in this diagram the two spaces. So, exactly we will talk about the enclosure. So, here I just want everybody to also know about pre-vertebral fascia. So, if we are talking about pre-vertebral fascia, when traced above, it is attached to the base of skull, and when traced below, it is attached to it merges with the anterior longitudinal ligament. It is merging with the anterior longitudinal ligament of the upper thoracic vertebra, T1 to T3 and oblique T4. So this is the extent. And one of an important feature which you should know the difference between the danger area of the neck and the retropharyngeal space. So I just want to enlarge this. So here in this diagram you can understand this. So see here, actually the red color area is the danger area of the space. So you can see this red color area which you are seeing here. This red color area is the danger space of the neck. The red color area is the danger space of the neck, and the yellow color area which you are seeing is the retropharyngeal space. This is the retropharyngeal space. The yellow color area is the retropharyngeal space as shown. So exactly, retropharyngeal space is lying anterior to the dangerous area of the neck, and exactly dangerous area is lying between the alar portion of deep cervical fascia and pre-vertebral layer. Anterior to it is the retropharyngeal space, which is lying between the alar portion of deep cervical fascia. Actually, pre-vertebral layer anterior extension is alar fascia and the posterior pharyngeal wall. So it is exactly lying between the posterior pharyngeal wall and alar fascia of deep cervical fascia. So that is important for you to note down. Then we will come to the carotid sheath. So here itself, if you want, you can write down difference between dangerous space of neck lies posterior to retropharyngeal space. Retropharyngeal, it lies posterior to retropharyngeal space of neck. Retropharyngeal space of neck is also called as glitty space. It lies between alar fascia and pre-vertebral layer of deep cervical fascia The retropharyngeal space, if I talk about retropharyngeal space, it lies between alar fascia and posterior pharyngeal wall Okay, actually the pre-vertebral layer of if we talk about the pre-vertebral layer of deep cervical fascia, it is extending into the axilla to form axillary sheath. So it will form axillary sheath. In the axillary region. So that is very, very important for you to note down. Now, actually there is one more thing which everybody should know is the carotid sheath. So if I talk about carotid sheath, its anterior wall is formed by pre-vertebral layer, pre-tracheal layer. So pre-tracheal layer of deep cervical fascia forms its anterior wall. Posterior wall is formed by pre-vertebral layer of deep cervical fascia. And in the anterior wall, you can see there is the location of ansa cervicalis. So there is a location of ansa cervicalis in the anterior wall, and posteriorly there is sympathetic chain. So posteriorly there is location of sympathetic chain, and it contains the there is sympathetic chain, and it contains IJV, carotid artery and vagus nerve, which is shown in this image. So done with this. Now the next topic is thyroid gland. So should we complete thyroid gland also? Dr. SK, it is called as dangerous area. I will tell you the reason why. Because it is actually, if you will see, the extent is from the base of the skull and going down till the level of longitudinal ligament of T3 and T4. So what happens? It can communicate with paraesophageal, retropharyngeal spaces. So posteriorly, it can communicate with the many important pharyngeal spaces. It is having many of the important pharyngeal spaces, and that is the reason there is communication there. So definitely there can be spread of infection, and if it is spread, it can go interior of the skull, it can go to the posterior to the pharynx, it can go to the retropharyngeal spaces, and it becomes very dangerous. It can involve the vertebrae also, intervertebral disc also, vertebral canal also, and can involve spinal cord ultimately. So now, okay, Dr. SK, now I want to complete, so let's start with the thyroid gland, and then I will give you a break, okay? So you have to note down the location, the capsules, the arterial relation, the venous drainage, the lymphatic, and the clinical correlation of the thyroid gland. So in this diagram, you can have an idea where thyroid gland is located. So you can see the location. So if I talk about the thyroid gland, this whole is the thyroid gland. So these whole part is showing you the thyroid gland. So you can see here this L for the lateral lobe and this I for the isthmic part. So exactly the location of thyroid gland is in relation to, it is lying anterior to C5, C6, C7 and T1 glands. If you will see, there is a extension from, there is an extension from pyramidal lobe. So there is a small pyramidal lobe from that of the isthmus which is extending, and above it is attached to the hyoid bone. So this extension is called as levator glandulae thyroidae. Thyroid gland is isthmic part is connecting the two lateral lobes, and it is lying close to the it is lying anterior to the tracheal rings, that is it is lying anterior to that of second, third and fourth tracheal ring. So you can just write down about the details. So write down thyroid gland. Thyroid gland is located in the lower part, in the lower part and in front of neck, opposite C5, C6, C7 and T1 vertebrae. C5, C6, C7 and T1 vertebrae. It is H-shaped. It is H-shaped. It is having two lateral lobes. It is having two lateral lobes. And the if it is having two lateral lobes, it is having two lateral lobes which extend upward. It extend upward to the oblique line of thyroid cartilage, to the oblique line of thyroid cartilage. If I talk about the isthmus of, if I talk about isthmus part of thyroid gland is located across midline, in front of second, third and fourth tracheal rings. Okay, now you can see here, this is actually the thyroid gland which has been shown. And you can see there is an extension from the thyroid gland isthmus which is forming, which is a pyramidal lobe. This extension is called as levator glandulae thyroidae, and which is attached to a hyoid bone. So it is attached to a hyoid bone as shown in this diagram. This is this pyramidal lobe extension is called as levator glandulae thyroidae. Done. Now let's talk about the capsules of thyroid gland. So the capsules of thyroid gland is having a outer aspect false capsule, and inside it is having a true capsule. So it's important to know the components. So exactly now itself I have told you false capsule of thyroid gland. If I talk about false capsule of thyroid gland, it is formed from pre-tracheal fascia. True capsule is formed from peripheral condensation of the thyroid connective tissues, and exactly if you will see the veins. So exactly if you will see the veins. So you can see here, these are the veins. And these veins are actually lying deep to the true capsules, deep. So the surgical incision in case of, so if we want to save the veins, we doesn't want any kind of bleeding, so surgical incision will always put between the true and the false capsules, between the true and false capsules. So here we are knowing the false capsule is formed by pre-tracheal layer of deep cervical fascia. Is formed from pre-tracheal layer of deep cervical fascia, and the veins are lying beneath, the veins are lying beneath that of the true capsule, and plane of surgical cleavage is between the true and the false capsule. Now it's important to know it's important to know about the relations of thyroid glands. It's very important to know about the relations of the thyroid gland. It is important to know exactly what is apex, what is so exactly you can see in this diagram. We can see the anterior border. We have, this is the thyroid gland, and if I talk about the thyroid gland, it is having apex, base, three surfaces and that of two borders. So its three surfaces are lateral surface, posterolateral surface and medial surface. It is also having a medial surface, and it is having a isthmic part, and it is having the two lateral lobe. It is having apex and the base. So you can just see the apex is directed upward towards the thyroid cartilage, which is actually sandwiched between two muscles. It is sandwiched between sternothyroid and inferior constrictor muscle. So it is very sandwiched. Base is lying lower down, as you can see in the diagram, and we have got three surfaces. So one by one I would like to show. Actually this is a transverse section of the thyroid gland of the neck, which is showing the relations of thyroid gland. So relations on the medial surface, medially if you will see the thyroid gland, if this is the whole outline of the thyroid gland, medially you can see it is related with the recurrent laryngeal nerves and the tubes, that is trachea, esophagus. Posterolaterally it is related with carotid sheath and its contents, and laterally it is related with the strap muscle, sternohyoid, sternothyroid, omohyoid, overlapped by sternocleidomastoid muscle. So please write down the heading relations of thyroid gland. Relations of thyroid gland. So if we talk about the relations, you can write down apex is directed upwards and is, so the apex is directed upwards to oblique line of thyroid cartilage, oblique line of thyroid cartilage. Apex is directed upwards and to the oblique line of thyroid cartilage, and is sandwiched between, between two muscles, inferior constrictor muscle, which lies medially, and sternothyroid muscle laterally, Okay, so this was about the apex. Now talking about the base. The base of thyroid gland is related to the fifth and sixth tracheal rings. Now talking about the lateral surface. Lateral surface is also called as superficial surface. So lateral surface is also called as the superficial surface of the thyroid gland, and it is laterally it is covered by three strap muscles. So it is covered by three strap muscle, and as I told you, this three strap muscle is overlapped by sternocleidomastoid muscle. So it is related with three strap muscle, that is sternothyroid, that is sternohyoid, and superior belly of omohyoid, and superior belly of omohyoid, and these three structures are overlapped by sternocleidomastoid muscle. So medially it is related with two tubes, that is trachea and esophagus. It is related with two muscles, and the two muscles is inferior constrictor muscle and cricothyroid muscle. It is related with two cartilages, that is cricoid and the thyroid cartilage. Cricoid and thyroid cartilage. So these are about medial relation. Now, exactly isthmus relation is already known to you. This is lying anterior to the tracheal rings. It is lying anterior to second, third and fourth tracheal rings. And in posterior border, we have got the parathyroid gland. So, done with this, these are the important relation. What is very, very important for thyroid gland, which has to be known to you, is the arterial supply, venous drainage, and arterial supply of thyroid gland is via superior thyroid artery, which is a branch of, external carotid artery, inferior thyroid artery, branch of thyrocervical trunk. There is thyroid imma artery also. If I talk about thyroid imma artery, it's actually a branch. From 30% cases only it is present. It can be a branch of arch of aorta or brachiocephalic trunk, and it is also having accessory thyroid artery from the branch of esophageal and tracheal artery. So you can see here, this is showing the superior thyroid artery, the inferior thyroid artery, and we have got the thyroid imma artery, which can be either the branch from brachiocephalic trunk or directly from arch of aorta. So this is about the arterial supply. Then we will go. So please write down arterial supply of thyroid gland. Write on the heading. Arterial supply of thyroid gland. The arterial supply of thyroid gland is following. It is via superior thyroid artery, branch of ECA, external carotid artery. It is via inferior thyroid artery, branch of thyrocervical trunk. Branch of thyroid, which is itself is a branch of subclavian artery, first part. Then we have got thyroid imma artery. Thyroid imma artery can be a branch from brachiocephalic trunk or sometimes from the arch of aorta. And the fourth source is accessory thyroid arteries. Accessory thyroid artery, which can be a source from esophageal artery or tracheal artery. So these are basically four arterial supply. These are basically four arterial supply to the thyroid gland. Now let's talk about the venous drainage. So if I am talking about the venous drainage, the important veins draining thyroid gland is superior thyroid vein, inferior thyroid vein, superior thyroid, inferior thyroid, middle thyroid vein. So we have got superior thyroid vein, we have got middle thyroid vein, we have got inferior thyroid vein, we have got also sometimes we have got Kocher vein. So actually it's important to know the drainage of these veins. So these are the four veins. So actually most of them, so exactly all the veins are draining in internal jugular. So superior thyroid vein drains into IJV, middle thyroid vein also drains into IJV. The vein of Kocher, which is sometimes arising between middle and the inferior thyroid vein, it also drains into IJV. The odd man out is only the inferior thyroid vein, which drains into left brachiocephalic vein. It drains into left brachiocephalic vein. Now talking about the lymphatic drainage. So lymphatic drainage has been asked. It is mainly draining into pre-laryngeal lymph node. It drains into pre-laryngeal lymph node. Also it drains into paratracheal lymph node, and ultimately it will drain into the deep cervical lymph node. So now done with this. So actually I would also like to talk about nerve supply. So nerve supply is basically, if you so basically if we talk about the nerve supply, nerve supply of thyroid gland is both parasympathetic and sympathetic. So parasympathetic is from vagus nerve. So parasympathetic is from the vagus nerve and derived from the recurrent laryngeal nerves, and sympathetic is derived from the cervical sympathetic ganglia. Basically the middle cervical sympathetic ganglia. Now, correlation, what is very, very important for your examination is to know the clinical anatomy of thyroid gland. Then I will come to one question. So, let's check with the students. So, exactly, it's very important that you should know the clinical anatomy of thyroid gland. Okay, dear. So, if I am talking about the thyroid gland, you have to know about this. So, I am just enlarging it. So, what you can see here, that this is the thyroid gland, and here you can see this. Let me just, yeah. So, I have outlined the thyroid gland, as you can see. Yeah. So, this is the outline of thyroid gland. So, this is 1 number and this is 2 number. So, exactly, superior thyroid artery is running close to external laryngeal nerve as shown in this diagram. Inferior thyroid artery is running close to the recurrent laryngeal nerve. So, this correlation is very important. This correlation is very important. That means when superior thyroid artery is ligated, and sometimes what happen in ligation of superior thyroid artery, there can be a chance of injury of external laryngeal nerve, and this will lead to the paralysis of the muscle, that is cricothyroid muscle. And if the inferior thyroid artery towards the base is ligated, it can lead to at times the recurrent laryngeal nerve injury, and that will lead to the paralysis of all the muscles of larynx except cricothyroid. So that correlation is very important. So here this correlation is very important. So many times clinical question has been asked from this. So I just want everybody to note down this. Superior thyroid artery, which is giving blood supply towards the apical part, apex part, is running close to which nerve? It is running close to external laryngeal nerve. And when external laryngeal nerve will injured, it can lead to the paralysis of cricothyroid muscle. If it is injured, cricothyroid muscle. So if it is injured, if superior thyroid artery has to be ligated and it is not properly done by the surgeon, they can injure the external laryngeal nerve, and this will lead to the paralysis of cricothyroid muscle. If I talk about inferior thyroid artery, the inferior thyroid artery give blood supply to the thyroid gland. It runs along with the base and it runs close to the recurrent laryngeal nerve. So when while ligating inferior thyroid artery, if there is an injury to the recurrent laryngeal nerve, it will lead to the paralysis of all intrinsic muscles of the larynx. So it will lead to the paralysis of all intrinsic muscles of larynx except cricothyroid. Why not cricothyroid? Because cricothyroid is supplied by external laryngeal nerve. That means the abductor of the vocal cord. What is the abductor of vocal cord? The abductor of vocal cord is posterior cricoarytenoid. That is also paralyzed, and the person will have an emergency condition, and emergency cricothyroidectomy has to be done. Now, the clinical correlation of thyroid gland injury, it can lead to the conditions of, as we know, the thyroid gland is surrounded by many important structures. It is surrounded by larynx, pharynx and all, trachea, esophagus. So, there can be a compression and the person can have dysphonia, difficulty in speaking, difficulty in eating, difficulty in airway passage, breathing. So, these are the conditions associated with thyroid gland swelling. Yes, thyroglossal cyst, that we know that there is foramen cecum, and thyroglossal cyst is not obliterated during the thyroid gland development. Okay, Dr. Punetem. So it is not obliterated. It can lead to the condition of thyroid fistula, thyroglossal cyst and fistula being formed. This can have external and internal communication. Now I want everybody to pay attention. Let's solve a MCQs related to it. And after this MCQ, let me just check. After this MCQ, I will start with a new topic, but I will give you a break. Okay, let's solve this MCQ. So let's start with this MCQ. I will give you a few seconds to answer. A 34-year-old male. Now, if I talk about a 34-year-old male is having a squamous cell carcinoma. It's having a squamous cell carcinoma, undergoes surgical neck dissection. While attempting to ligate the inferior thyroid artery, the surgeon accidentally damages the nerve which is lying in close proximity to it. Okay. Which of the following structure is most likely to be damaged? Which of the following structure is most likely to be damaged? So you can see here, I will just rub this. So actually you have to see that surgeon is for the operation, and here the inferior thyroid artery is ligated. So which of the following nerve is closely associated with it and can be a chance of their injury? So I got an answer from Nitin. Nitin is telling B. What about others? I got an answer for Punit, as so everyone has given absolutely right answer. Just now I have I have explained it also, absolutely correct. Recurrent laryngeal nerve is not the right answer. Superior laryngeal is not the right answer, as its branch external laryngeal will be ligative in superior thyroid artery region. Ansa cervicalis is located anterior to the loop, anterior wall of carotid sheath. Hypoglossal nerve will give innervation to tongue, and accessory nerve will give innervation to sternocleidomastoid and trapezius muscle. That means the right answer is recurrent laryngeal nerve. So inferior thyroid artery, which is a branch of thyrocervical trunk, which is a branch of subclavian artery, runs along with the recurrent laryngeal nerve. Superior thyroid artery runs along with the external laryngeal nerve. So, so that is the right answer, absolutely correct. Yes, superior laryngeal nerve. If we talk about superior laryngeal nerve, you can just have superior laryngeal nerve is a branch of vagus. It's a branch of vagus nerve, and superior laryngeal nerve divides into external laryngeal nerve and internal laryngeal nerve. That means there is a chance of external laryngeal nerve paralysis, and external laryngeal nerve is giving innervation to cricothyroid. Okay. So now vagus nerve, if I talk about recurrent laryngeal nerve, it will have the innervation. So all the important structures will get injured. So also superior laryngeal nerve is not the right answer. Ansa cervicalis is a nerve loop giving innervation to, yes, Dr. SK, yes, Dr. SK, please tell. Yes, Dr. SK, please tell. Ansa cervicalis is giving innervation to infrahyoid muscle. Hypoglossal nerve is giving innervation to all the muscles of the tongue. So exactly, you have to know this structure very nicely. Yes, ma'am, superior laryngeal nerve damage, if it is more, when the as we know, superior laryngeal nerve, exactly, this is for Dr. SK. Superior laryngeal nerve divides into two branches. One is external laryngeal nerve and the other is internal laryngeal nerve. So external laryngeal component is damaged, then the cricothyroid muscle is paralyzed. If the internal laryngeal component is damaged, the sensory innervation of the mucosa of the larynx cavity above vocal cord is injured. So now the next topic is pharynx and larynx. So you will get the detail. SK, got it? If the superior laryngeal is injured, then both the branch will be gone. External and internal laryngeal. External will be injured, cricothyroid muscle paralyzed. Internal laryngeal nerve is injured, then the mucosa innervation of laryngeal cavity, sensory innervation above the vocal cord is gone. Internal laryngeal artery, its internal laryngeal artery is branched from inferior thyroid artery. Okay, so generally, so that is with internal laryngeal artery ligation with nerve damage, that is in relation with thyroid membrane. But common site of injury is this. Okay, Dr. SK, common site of injury is this. If I am telling, if the whole bunch of superior laryngeal gone, both internal and external is gone. Okay, internal laryngeal component basically will be more damaged as you go towards the thyroid membrane or you go towards the pariform fossa. Okay, pariform fossa. So I am giving you a break now. I will come with a new topic after the break and we will start. So let's start with the session now. The next two topic which is very important, which I want to cover, the two more topics are there. One is the pharynx and the larynx. So this two topic is highly important for the question being asked for your examination. So we will, I would like to cover up both these topics. One is pharynx and the other is larynx. So let's start with this. The idea is that you have to know about the pharynx also and you have to know about the larynx also. So firstly, let me cover up the pharynx part. Actually, pharynx is will be divided again into different components, that is nasopharynx, oropharynx and laryngopharynx. So that all part you have to know. So exactly in this diagram, the parts of pharynx has been shown to you. So exactly, if we talk about the pharynx, it is having an extension which has been shown. So it is exactly starting from the base of the skull. So superiorly, the pharynx is extending from the base of the skull which is related to the body of sphenoid, and inferiorly it is continuous with the esophagus at the level of lower border of cricoid cartilage. So that is the whole extent of the pharynx. Posteriorly there lies pre-vertebral fascia, and anteriorly on each side there will be nasal cavity, oral cavity, and the larynx. So this is an idea of the pharynx location. The pharynx is divided into three parts: nasopharynx, oropharynx, and laryngopharynx. The part of the pharynx which is lying posterior to the nasal cavity is called as nasopharynx. The part of the pharynx which is lying posterior to oral cavity is oropharynx, and the part of the pharynx which is lying posterior to laryngeal cavity is called as laryngopharynx. So first thing is to know the overall boundary of the pharynx, then we will talk about each component. So I just want everybody to know about the extent of pharynx. So when I am talking about the superior aspect of the pharynx, superiorly it extends to the base of skull, and inferiorly it extends to or continues below with the esophagus at the level of cricoid cartilage, at the level of cricoid cartilage. Posteriorly it is having the pre-vertebral fascia, and anteriorly there lies the opening of nasal cavities, the mouth, and the larynx. Okay. Okay, so this is overall pharynx part, and we have got the nasopharynx, oropharynx, and laryngopharynx. So firstly I would like to tell about the nasopharynx. Exactly, if I talk about the part of nasopharynx, that means nasopharynx is lying behind the nose. It is lying behind the nose. Oropharynx is lying behind the oral cavity, and laryngopharynx is lying behind the larynx. Now actually this is the head and neck sagittal section. So this is exactly the sagittal section of head and neck. So this is the sagittal section of head and neck, where you can see the important structures. So you can exactly see the important structures in the sagittal section of head and neck, and you can absolutely appreciate that the boundaries of the sagittal section of head and neck. So you can appreciate the boundaries of sagittal section of head and neck, and you can see the nasopharynx here. So firstly I would like to talk about the nasopharynx. So in this image I am talking about the nasopharynx. So if I am just enlarging this. So when I talk about the nasopharynx, it is having important structure. So one of the structure which is shown here, this is the nasopharyngeal tonsil. So at the junction of roof and the posterior aspect, we have got nasopharyngeal tonsil, that is the lymphatic aggregation. Other than that, here you can see there is an opening of eustachian tube, and it is overlapped. So there is also an opening of eustachian tube which is called as auditory tube, and above the eustachian tube there will be aggregation of lymph node that will form tubal tonsil. So exactly these are certain important things which will be seen in the nasopharynx. So write on the heading nasopharynx. Nasopharynx. So exactly first is to know the extent of the nasopharynx. So if I talk about the extent of nasopharynx, it lies behind the nasal cavity and above the level of soft palate. So in this diagram you can see this is the soft palate. So exactly this is the soft palate. So from here to here, posterior to the nasal cavity and above the level here you can see posterior to the nasal cavity and above the level of the soft palate, this whole area is called as the area of nasopharynx. Nasopharynx lies behind the nasal cavity. It is located behind the nasal cavities and above the soft palate, above the soft palate. Now important features. So let's talk about the important features of nasopharynx. So one is the aggregation of lymphoid tissue. So if you will see the aggregation of lymphoid, so there is an aggregation of lymphoid structures, there is an aggregation of lymphoid tissues, and these aggregation of lymphoid tissues is collection of lymphoid tissues lying beneath the mucous membrane, and exactly this collection of lymphoid tissues is lying beneath the mucous membrane at the junction of the posterior and superior aspect. This will form nasopharyngeal tonsil. This will form nasopharyngeal tonsil. The other features is this will form the nase. So exactly, I just want everybody to see this. This is the pharyngeal tonsil called as nasopharyngeal tonsil. So exactly, if you will see in this diagram, you can, if this is the outline of nasopharyngeal tonsil, which is shown in the green color, you can see it is lying posterior to the nasal cavity, and it is exactly lying at the junction of roof and the posterior aspect, and this collection of lymphoid aggregation is called as nasopharyngeal tonsil. So that is exactly called as nasopharyngeal tonsil. Other than that, you can see the openings here. So you can see the auditory opening. So here is the auditory opening, which is having a, this is the orifice of the auditory tube, and above it the collection of lymphoid structure is forming tubal tonsil. So this is again showing the image of nasopharyngeal tonsil. The other important structure which is seen is orifice of auditory tube. What is the other name of auditory tube? It is also called as pharyngotympanic tube. The other name of auditory tube is, it is also called as pharyngotympanic tube. So there is an orifice of pharyngotympanic tube, which is also called as auditory tube, which is also called as Eustachian tube. It is also called as Eustachian tube. Now there are two folds. There are two folds. So orifice is there, and there is also folds. So on upper aspect, I've got thyroid. This pharyngotympanic tube, there is collection of lymphoid tissue. That is on the upper and posterior aspect. That is on the upper. So if we talk about collection of lymphoid tissue, the collection of if we talk about the collection of lymphoid tissue, the collection of lymphoid tissue is lying on the upper and posterior aspect of auditory tube, and this is called as tubal tonsil. This is called as tubal tonsil. Now, sometimes what happens, this is the nasopharyngeal tonsil. So if nasopharyngeal tonsil enlarges, if it is enlarging, if nasopharyngeal tonsil enlarges, it will lead to the formation of adenoid. It will lead to the formation of adenoid, and it can lead to mouth breathing. So it can lead to the condition of mouth breathing. It becomes very difficult for the patient to have breathing from the nose. Now, other than that, actually there is also actually fold is there in auditory tube above. So there is a fold. So in auditory tube there are fold. There is a two folds which is diverging here, and they are salpingopharyngeal fold and salpingopalatine fold. So a collection of lymphoid tissues are there, and there are two folds which is extending. So mucosal fold is extending from this elevation. So if you will see here, mucosal fold. So here you can say, here you can write from tubal tonsil, mucosal fold, from tubal tonsil mucosal fold extends. That is two mucosal fold extends, and the name of that fold is, the one is called as salpingopharyngeal fold. The one fold is called as salpingopharyngeal fold, and the other is called as salpingopalatine fold. Salpingopalatine fold. So there is a salpingopalatine, and there is salpingopharyngeal, and there is salpingopalatine fold. Salpingopharyngeal fold is containing salpingopharyngeus muscle, And the other muscle which it contains is levator, vili palatini muscle. Now there is also a pharyngeal recesses. One more point is important for the nasopharynx. There is a pharyngeal recesses, and this pharyngeal recesses is a deep depression. It is a deep depression behind tubal tonsil. It is called as pharyngeal recesses or called as fossa of Rosenmuller. Fossa of Rosenmuller. Now the next topic is oropharynx. The next topic is oropharynx. So if I talk about oropharynx, it is located behind the oral cavity. It is located behind the oral cavity. So the roof is formed by the soft palate and floor is formed by posterior 1/3 of the tongue. So exactly if I talk about the oropharynx, its roof is formed by the soft palate and its floor is formed by the posterior part of the tongue. Extent ki baat kare, if I am talking about the extent of oropharynx, it is lying below the soft palate and above the epiglottis. I just want you to show this image. See here. So exactly if we talk about the extent, so it is lying below the soft palate and above the epiglottis. So this is the epiglottis structure. So this is the epiglottis and this structure is the soft palate. This is epiglottis. So in between these two structure where we have got the location of oropharynx. So here will be O for oropharynx, this will be NP for the nasopharynx, and below it we have got the laryngopharynx. So write down about the oropharynx. Oropharynx extends from soft palate to epiglottis, and actually at the entrance of the oropharynx, actually I just want to tell you about the Waldeus ring. So there is a Waldeus ring, and this is very, very important for you to note down. So everyone, if you have got any doubt, you can ask me. I will just check with the students. Okay, live. I will take many topics. Don't worry. At what time class gonna start? So it's already started. Okay. So this is the Waldeus ring, which is formed by the continuation of the. Actually, we know that there is a palatine tonsil which is lying in the tonsillar fossa. So exactly there is a tonsillar fossa. So there is a tonsillar fossa in which palatine tonsil lies. So we have got posteriorly nasopharyngeal tonsil, we have got laterally palatine tonsil and tubal tonsil, and anteriorly there is a lingual tonsil. So all these together is forming the Waldeus ring, and this is obstructing any kind of entrance of any kind of infection and invagination entering into or infecting the cavities of the infecting the any kind of infection is not drained inside, so that is very important. So actually, then we will talk about laryngopharynx. So if I talk about laryngopharynx, here we will also talk about uh, the smuggler fossas and all. Laryngopharynx is lying behind the laryngeal cavity. So if I talk about the general features or extent, so it is exactly exactly located. So it is located between in between. It is epiglottis. So it is extending from epiglottis to the cricoid cartilage, and the cricoid cartilage level is corresponding to C6 cervical vertebra. So if you want to exactly know laryngopharynx, it is lying posterior to the larynx, but if you want to know exactly extent of laryngopharynx, it is extending from the epiglottis above to the cricoid cartilage below, that is C6 cervical vertebra. So here you can see, and laterally there is a space. So in the lateral aspect you can see there is a space, as you can see. So exactly, this space is also very important for you to note down. Why? Because this is called as pariform fossa. So exactly, pariform fossa is a deep recesses narrow below the anterior part of the lateral wall of the laryngopharynx. So it is exactly very important for you to know. So exactly, अगर हम pariform fossa की बात करें, we are talking about the pariform fossa. You can see this is the pariform sinus which has been shown. So medially there is array epiglottic fold. So you can see here on the medial aspect there is array epiglottic fold. So medially there is array epiglottic fold, and laterally there will be a mucous membrane over the lamina of thyroid cartilage, and also there is the pariform fossa. There is also epiglottis, as you can see. So exactly above there is an epiglottis part, and medially there is array epiglottic fold. So exactly, it's a lateral food channel. So pariform fossa is a lateral food channel lying on either side, as you can see, and it is actually a deep broad recesses which is lying on the either side of laryngeal inlet. So please write on. Pariform fossa. So if I talk about pariform fossa, it is a deep recesses on each side of laryngeal inlet. On each side of laryngeal inlet, this is a deep recesses. So it's also important for you to know the boundaries. So if I talk about the boundaries, so please write down the boundaries, important boundaries. If I talk about the boundaries, medially there is array epiglottic fold, which is covering the quadrangular membrane. So it is covering the quadrangular membrane. Then we have got the mucus. Laterally we have got the mucosa, which is covering the thyroid cartilage, and it covers the thyrohyoid membrane and thyroid cartilage. And above there is epiglottis vallecula. So this is about the boundary of pariform fossa, and the clinical importance of pariform fossa is that sometimes what happens is also called as smuggler fossa. So exactly what happens, there can be a malignant growth in this area, or there can be ingestion of some foreign structures, fish bone or all can accumulate, and care should be taken to take the foreign bodies. Actually, why? Because there can be injury to internal laryngeal nerve in this area. So the reason is why? Because internal laryngeal nerve will be injured in this area, and that protective reflex, that is a cuff and protective reflex, will be gone, and it can lead to the blockage, and it can lead to asphyxia. Okay, now let's talk about the walls. So let's talk about the pharyngeal wall. So if I talk about the pharyngeal wall, the pharyngeal wall is having following layers as you proceed. So mucosa, pharyngobasilar fascia, the submucosa, the constrictor muscle and the longitudinal muscle, and the outermost layer is the buccopharyngeal fascia. The outer layer is the buccopharyngeal fascia. So the pharyngeal wall is made of mucous membrane which is forming from inside to outside. It is made of mucous membrane. It is made of mucous membrane. It is made of pharyngobasilar fascia. It is made of muscular coat, that is the pharyngeal muscle, and it is made of buccopharyngeal fascia. Okay. Now done with this, now we will talk about the constrictor muscles. So now we will talk about the muscles. So actually if I talk about the muscles of the, so this is the diagram, this is the image which is showing longitudinal muscles of the pharynx. This is showing longitudinal muscles of pharynx. So this is showing the longitudinal muscles of pharynx, salpingopharyngeus, stylopharyngeus, palatopharyngeus and all. And this is showing the constrictor muscle. So we have got superior, this is showing the superior, we have got superior constrictor muscle, we have got the middle constrictor muscle, and we have got the inferior constrictor muscle. So all these are forming the muscles of the pharynx, and what is very very important for you is to know the gaps in this constrictor group of muscles. So it's very important to know the gaps in this constrictor muscles and the structures passing through this gap. So actually I would like to explain, and then I will write it about this. Then we will talk about. So exactly this is the base of skull. So the first gap is between the base of skull and the superior constrictor muscle. The second gap is between the superior and middle constrictor muscle. The third gap is between the middle and the inferior constrictor muscle, and the fourth gap is below the inferior constrictor muscle. And you have to know the structures passing through all these spaces. So actually the gap between the base of skull and upper aspect of the superior constrictor muscle is also called as sinus of Morgagni, and the structures passing is four. We have got auditory tube, we have got ascending pharyngeal artery, palatine branch, ascending palatine artery, auditory tube and levator villi palatine. Four structures are there. If we talk about the structures which is passing between the superior and middle constrictor muscle, just two structures passes, stylopharyngeus muscle and the innervation of stylopharyngeus muscle, that is glossopharyngeal nerve. The middle constrictor, inferior constrictor, we have got another gap in which passes the superior laryngeal vessels and internal laryngeal nerve. Below inferior constrictor, we have got a space that is called which is also called as the tracheoesophageal groove, and through this passes laryngeal nerve and internal laryngeal vessels. So I just want everybody, to write this. So please write it. So I just want everybody to write this important point. On one side write down gap, and on other side write down structure passing through the gap. So one side we have got the structures passing through the gap, and other side we have got a gap. So one by one you will write it. So let's talk about the first gap. So if I'm talking about the first gap is between so write down gap is between base of skull, the gap is between base of skull and upper concave border of superior constrictor muscle. and actually this gap is called as sinus of Morgagni. And the structures passing through this gap. So we have got 4 structures passing through this gap. So please write down, we have got 4 structures passing through this gap, and they are auditory tube, they are levator villi-palatini muscle, levator villi-palatini muscle, they are ascending palatine artery, they are palatine branch of ascending pharyngeal artery, palatine, they are ascending palatine artery, and they are palatine branch of ascending pharyngeal artery. This is the first gap. Now talking about the next gap, the second gap is between superior constrictor and the middle constrictor muscle. So I am writing in short, between SC, superior constrictor, and the middle constrictor. This is the second gap, and 2 structures are passing through this gap: stylopharyngeus muscle and the innervation of stylopharyngeus muscle. So we have got a muscle and its nerve supply. So write down stylopharyngeus muscle and its nerve supply, that is glossopharyngeal nerve. Okay, now the third gap. The third gap is between middle constrictor and inferior constrictor muscle. The third gap is between middle constrictor and inferior constrictor muscle. So that is internal laryngeal nerve, that is internal laryngeal nerve, and we have got superior laryngeal vessel. Superior laryngeal vessels. Now talking about the fourth gap. So that is the gap. If I talk about the fourth gap, it is between, or it is below the inferior constrictor. This gap is below inferior constrictor muscle. And these are the structures passing is the recurrent laryngeal nerve, and inferior laryngeal vessel. So done. So exactly all these structures are passing. So we can see all these structures are passing between this gap, and I want everybody to know about these gaps and the structures passing, because this is highly important. So I just want everybody to know this. Why? Because this is highly important. Yes, you are right. So actually why this is very important, highly important, is that you should know all these structures and the gap. The next is to know about, so we have done with the longitudinal muscles. If I am talking, yes, longitudinal muscle, we have got 3 here. That is the palatoglossus muscle. No, here we have got, so we have got, in case of tongue, that is we have got stylopharyngeus muscle. We have got salpingopharyngeus muscle, and we have got palatopharyngeus muscle. These are the 3 longitudinal muscles. Now, exactly the next important point is to know the nerve supply, the venous drainage and all. Then, so exactly if I talk about the nerve supply of the pharynx. So firstly I would like to talk about motor supply. So all the muscles of pharynx, all the muscles of pharynx are innervated. All the muscles of pharynx are innervated. All the muscles of pharynx are innervated by cranial root of accessory nerve via pharyngeal branch of vagus, which is carrying pharyngeal branch of vagus. Actually, the innervation is via pharyngeal nerve plexus. And we know that these nerve plexus is lying over middle constrictor muscle. So this is located over middle constrictor muscle. So this is located on the middle constrictor muscles of the pharynx. This is located on the middle constrictor muscles of the pharynx. Next important thing is to know the formation of pharyngeal nerve plexus. So in this diagram you can see pharyngeal nerve plexus. So if I talk about pharyngeal nerve plexus, it is formed by pharyngeal branch of vagus. It is formed by the pharyngeal. So this nerve plexus is formed by, if we talk about the formation, it is formed by pharyngeal branch of vagus, pharyngeal branch of glossopharyngeal nerve, and also by pharyngeal branch from the superior cervical sympathetic nerve. Superior cervical sympathetic ganglion. So branches from the superior cervical sympathetic ganglion. This is all the pharyngeal nerve plexus. So done with this motor supply. If you just want to know about the sensory innervation, so if you just want to know about the sensory innervation, so it's important to know that so if you want to know the sensory innervation, you can just write down sensory supply of the pharynx. So here we have got three parts: nasopharynx, we have got oropharynx, and we have got pharyngopharynx. We have got laryngopharynx. So basically, if I talk about nasopharynx, it is getting innervation from the pharyngeal branch of pterygopalatine ganglion. Pharyngeal branch of pterygopalatine ganglion, branch from maxillary. Oropharynx is getting its innervation by glossopharyngeal nerve, and laryngopharynx is getting innervation from internal laryngeal nerve. Done? Is done by internal laryngeal nerve. Okay, so done with this. Now, okay, if you want to know the arterial supply and venous drainage also, you can write it. Then we can move on to the larynx. So I just want everybody to write this also. Okay, now let's talk about the venous drainage. So venous drainage is via pharyngeal venous plexus. So venous drainage. So you can just write down. Yeah, venous drainage of pharynx. If I talk about venous drainage of pharynx, it is via pharyngeal venous plexus. And we know that pharyngeal venous plexus will ultimately drain into IJV, internal jugular vein. So done with this. So we have done with this. Now the next topic which I want to start is the larynx. So I will just cover up the larynx, and we will have the so last topic which I want. Yes, you are absolutely right, Venkatesh. You are absolutely right. Now the next topic is the larynx. What is important in larynx is the cartilages of the larynx, which you have to know. So you have to know about the cartilage. You have to know about the ligaments. You have to know about the name of extrinsic, intrinsic muscles of the larynx, intrinsic muscles of the larynx, and the action of these muscles. You have to know about the nerve supply, vasculatures, and the clinical anatomy. So let's start with the larynx. So exactly, if I talk about the larynx, the other name of larynx is, it is also called as the voice box. So it's also called as the voice box, and it is extending from C3 to C6 vertebra, and it connects it is continuous with that of the trachea above. So you can see this is the larynx, this is the extent of the larynx, and the larynx is lying anterior to laryngopharynx, and its extent is from C3 to C6 cervical vertebra. So that is the overall extent of the larynx. Now it's important, one time there was a question in the FMG exam was about the larynx, which is the paired cartilage and which is the unpaired cartilage. So total, how many cartilages are there in larynx? So total we have got 9 cartilages. In this 9 cartilage, we have got 3 paired and 3 unpaired. So here 3 paired one is, yes, you are right dear, the 3 unpaired is cricoid, epiglottis, and that of thyroid, and 3 paired one is arytenoid, corniculate, and cuneiform. So total it becomes how many? Total it becomes 9. Yes dear, I just want everybody to see this image. Actually, if you will see this image, you can see the cartilages. You can see thyroid cartilage, the epiglottis, which is having the shape of a leaf like, arytenoid, cricoid cartilage. So we have got and also the 2 small cartilages, which is exactly seen in this diagram. So you can see here we have got the cuneiform and we have got the corniculate cartilages. Okay, so together these are the cartilages. What is important for you is to know which cartilage is made of hyaline cartilage and which is made of elastic cartilage. So generally the thyroid cartilage is protruded outward, forming the Adam's apple, larger in males and there is also inside and outside the laryngeal cartilages are connected, forming the extrinsic membrane and ligament and intrinsic membrane and ligament. Thyroid cricoid. Yes, Venkatesh, you are right. Corniculate and cuneiform is elastic. Not only that, we have got epiglottis, which is also elastic, and the apex of arytenoid is also elastic. Okay, Venkatesh. So please write down thyroid cartilage, cricoid cartilage, arytenoid cartilage. Arytenoid cartilage, except the apex. So all these 3 cartilages are made of hyaline cartilage. And if we talk about 4, 5, 6, you just write down. Apex of arytenoid cartilage, apex of arytenoid cartilage, epiglottis, corniculate and cuneiform, corniculate and cuneiform cartilage. So these all cartilages, these are all cartilages are made of elastic cartilage. These are of which variety? These are of elastic cartilage variety. These are of elastic cartilage variety. So the composition of cartilage is also very, very important for you to note down. So actually we have just now appreciated, so exactly we have just now appreciated that larynx is having cartilages and membrane on outer aspect, and it is having larynx is also having cartilages, it is having membrane and ligament in inner aspect. So all the cartilages of larynx to work as a single entity, it work together. If we want to make all the cartilages working as a single entity, so what is important for us is to that we should know about, so that is important that we should know that there will be membrane and ligament which is connecting the larynx cartilage so that it work as a single structure. So laryngeal membrane and ligament which is supporting this cartilaginous framework on outer aspect is called as extrinsic membrane and ligament, and the larynx cartilage and cartilage membrane ligaments which is protecting it or connecting the larynx cartilage on inner aspect, the membrane and the ligament which is supporting it from the inner aspect is forming intrinsic ligament of the larynx. So it is important that you should know the name of important extrinsic and important intrinsic ligament. So here it's very important that you should appreciate one of the ligament, that is thyroid membrane. So this is one of a very important membrane which is called as thyroid membrane. Why it is very important? Actually, this thyroid membrane, if I talk about this thyroid membrane is pierced by, so this thyroid membrane is pierced by internal laryngeal nerve and superior thyroid artery. So why it is very important is that because this thyroid membrane is pierced by internal laryngeal nerve and superior thyroid artery. So thyroid membrane is connecting. So here you can see this is the thyroid cartilage, and exactly this is the hyoid bone, and this is the thyroid cartilage. So exactly, thyroid cartilage and hyoid bone is connected by a green structure, that is thyroid membrane, and it is pierced by two important structures, internal laryngeal nerve and superior laryngeal artery. So in the MCQs and in the previous year of examination, it has been asked that thyroid membrane is pierced by two important structures. The answer is it is pierced by internal laryngeal nerve and superior thyroid artery. So first important membrane which you have to know is the thyroid membrane. The thyroid membrane is spanning between. So what is this, from where to where it is extending? If you will see the thyroid membrane in this diagram, it is spanning between the thyroid cartilages and the hyoid bone. Okay, so it is called as thyroid membrane, and it is pierced laterally by superior laryngeal vessel and internal laryngeal nerve. So this is very important point for your MCQ, that it is pierced by. It's very important for you to note down that it is pierced by superior laryngeal. It is pierced by the superior laryngeal vessel and internal laryngeal nerve. This is important point for the MCQs. Okay. Now, if I talk about other ligaments, we have got median thyroid ligament. Actually, the thickening of thyroid membrane medially is median thyroid, laterally is lateral thyroid ligament, and hyoepiglottic ligament. So, if you remember the name only, you can understand hyoepiglottic ligament. When I am using the word hyoepiglottic, it is connecting the epiglottis and hyoid bone. So, here you can see this is the lateral thyroid ligament. This is thyroid membrane. And here you can see this is the hyoepiglottic ligament, which is connecting the hyoid bone and the epiglottis. This structure which you are seeing is E for epiglottis, and this is the hyoid bone which you are seeing. Now, crico. The other two important extrinsic membrane and ligament is cricotracheal ligament, connecting cricoid cartilage and that of the trachea. Median cricothyroid means it is connecting the cricoid and thyroid cartilage medially. So all these names which I have just told you, like thyroid membrane, median lateral thyroid ligaments, I have told you hyoepiglottic ligament, cricotracheal ligament, median thyroid ligament, all these are extrinsic membrane and ligament of thyroid of the larynx. So let's talk about intrinsic. The next important point is to know about the intrinsic. So in intrinsic category, we have got two membrane and we have got two ligaments. So in intrinsic category, we have got two membranes and two ligaments. So if I talk about the membrane, two membranes is, we have got a quadrangular membrane and we have got a cricovocal membrane. So in this diagram, you can see we have got a quadrangular membrane and we have got a cricovocal membrane. So exactly, if I talk about quadrangular membrane, it is important for you to note down that it is spanning between the arytenoid cartilage and lateral aspect of epiglottis. So what will be the attachment of quadrangular membrane? It is exactly located in between arytenoid cartilage and lateral aspect of epiglottis. It is having a free upper and lower border, and its lower border is forming the vestibular ligament. Its lower border is forming the vestibular ligament. So here you can see this is the, so I just want everybody to concentrate on quadrangular membrane. You can see this is the quadrangular membrane which is spanning between the arytenoid cartilage. You can see this is the arytenoid cartilage and that of epiglottis, and its lower free margin is called as vestibular ligament. So its lower free margin here is called as the vestibular ligament. Done. Now the other one is cricovocal. So when we are talking about the cricovocal, you can see here this is the another membrane which is lower down, you can see. So I just want to say this is the quadrangular membrane connecting arytenoid and epiglottis. Lower down we have got, this is the muscular process and this is the vocal process of arytenoid. So it is connecting the arytenoid and it is also merging with the thyroid cartilage. Here you can see here it is merging, and its upper aspect we have got the vocal ligament, so it is having the vocal ligament. So altogether I just want to write down the name. We have got quadrangular membrane and cricovocal membrane, and two ligaments we have got, the vestibular ligament and the vocal ligaments, vestibular ligament and the vocal ligament. So four of these structure is forming two intrinsic membrane and two intrinsic ligaments. So that is very, very important for you to note down. Now let's talk about the muscles of the larynx. Yeah, so if I talk about, so basically I am concerned with the intrinsic muscles of the larynx, not the extrinsic one, because intrinsic muscles of the larynx are is actually extrinsic is the surrounding muscle, that is supra and infrahyoid muscles are there, that is extrinsic. But when I talk about intrinsic muscles, we have got many important muscle in this category: posterior cricoarytenoid, lateral cricoarytenoid, thyroepiglotticus, aryepiglotticus, oblique arytenoid. So many muscles are there, and I just want that you should understand these muscles on the categorization of their action. So according to the action you have to understand these muscles. So we will categorize these muscles. So important muscles has been shown here. As you can see here, we have got oblique arytenoid, we have got transverse arytenoid, abductor. Yes, absolutely right, Venkatesh. The most important of it is abductor of larynx. Only one abductor is there, and the name is posterior cricoarytenoid. Posterior cricoarytenoid is the only one abductor. We have got transverse arytenoid, we have got thyroarytenoid, lateral cricoarytenoid. So one by one I will tell you. So actually we can categorize this muscle according to their action. Here there is one more muscle. Here on the posterior aspect, we have got posterior cricoarytenoid, we have got cricothyroid muscle also, which is the tensor. So the muscle here, this is very important, the muscle that is causing abduction of the larynx, which is causing abduction of the vocal cord, they are posterior cricoarytenoid, very important for the MCQ. And we have got a Venkatesh which has given absolutely the right point about this. Now we have got sphincteric action of muscle, transverse crico. So we have got sphincteric action muscle, transverse arytenoid, oblique arytenoid, and thyroepiglotticus. Actually, this cricothyroid muscle is very important, and this has also been asked in MCQ. Which muscle is having tensioning effect on the vocal cord? And the answer is cricothyroid muscle is having tensioning effect on the vocal cord. So you can see here, this is the cricothyroid muscle, a very unique muscle having innervation by external laryngeal nerve. All the muscles, so if I talk about all the muscles of the larynx, it is getting innervation from recurrent laryngeal nerve, except the odd man out is cricothyroid muscle, which is getting innervation from the external laryngeal nerve. So I just want everybody to know about the laryngeal cavity also. Actually, the laryngeal cavity, if I, so you can see here, this is the aryepiglottic fold and epiglottis. So here we have got a false vocal cord. This is the lower part, this is the false vocal cord, vestibular fold, and lower down we have got a vocal fold. So in between this elliptical space we have got the glottic compartment. Above it we have got the supraglottic compartment, lower to it we have got infraglottic compartment. So laryngeal cavity is extending from laryngeal inlet to the lower border, it get continuous with, if we talk about the whole continuation of the larynx, so exactly laryngeal cavity is arising from the laryngeal inlet to lower down, it continues with the trachea. It is divided into it is divided in two parts by the vocal fold, and the narrow part between the vocal fold is called rima glottis. So rima glottis is anteroposterior narrow part of the laryngeal cavity. The portion of the larynx which is lying above vocal fold is supraglottic compartment or vestibule fold. So exactly the portion, so exactly what I told you, the portion lying below the vocal cord is infraglottic compartment, and that is very important. So here you can see the false and the true vocal fold. This is the glottic compartment, this is S for supraglottic, and this is I for infraglottic compartment of the larynx. And what is very important is to know the narrowest part of the laryngeal cavity, that is the rima glottis. And actually in different aspect, the shape of rima glottis changes. So I just want that you should be aware of this, that you should be knowing about the rima glottis. So exactly, it's important to know the rima glottis important changes of this. So we will talk about rima glottis important changes, how it is changing. It's actually rima glottis is an opening between two true vocal cord. So exactly you can write this firstly. So rima glottidus is opening between the two true vocal cords anteriorly. So it is an opening between the two vocal cord anteriorly and arytenoid cartilage posteriorly, and arytenoid cartilage posteriorly. So actually it is a narrow space, it is a part of the larynx, it's a narrowest space which is called as rima glottis, which have got the vocal cord anteriorly, and posteriorly it is having the arytenoid cartilage. Okay, it is having the arytenoid cartilage. So exactly rima glottis is the narrowest part. In case of males, the rima glottis is approximately 23 to 24 mm, and in case of females is slightly more narrow, it will be 17 to 18, 19 mm. That is a range. Okay, so rima glottis is an aperture between two true vocal cord anteriorly, and it is an aperture between the vocal to the vocal process of arytenoid cartilage posteriorly. So this is very important for you to understand what is exactly the rima glottis. If you want to know exactly this space, you can more elaborate it. So you can just write on rima glottis is an aperture, it's an aperture between, it is an aperture between the two true vocal cords anteriorly and the base and vocal processes of two arytenoid cartilage posteriorly, two arytenoid cartilage posteriorly. Okay, now here exactly this is shown, and we are knowing the we are knowing about this rima glottis shape changes. So exactly I just want that during quiet respiration, the rima glottis shape, you can see it's actually a pentagonal type of feature. You can see it's a pentagonal. During speech, it is linear chunk, so it is like a pentagonal shape. The space between the rima glottis, it is like a linear chunk. In whispering, it is actually so that spaces is very important. So exactly if you talk about exactly normal or quiet respiration, it is exactly pentagonal type of condition. In forced respiration, it will be having the forced inspiration. You can see funneling is there for the lower aspect. As you can see in whispering, it is actually like a linear chunk. Okay, so exactly that is important. So the shape has been shown you. You can just go through this. Now talking about the next part is the nerve supply. Nerve supply, as I told you in the larynx case, the nerve supply is all the muscles are supplied by posterior cricoarytenoid. And so exactly if I talk about sensory, so I just want to show you this image. Superior laryngeal nerve is there, which divides into internal and external laryngeal. External laryngeal will give innervation to cricothyroid muscle. Recurrent laryngeal nerve will give innervation to all the muscles of the larynx. This internal laryngeal nerve will give innervation, sensory innervation to upper part of the laryngeal cavity. So it is giving sensory innervation to upper part of laryngeal cavity. Recurrent laryngeal nerve will give sensory innervation to the lower part of laryngeal cavity. So sensory innervation of the glottic and the upper part is by internal laryngeal nerve, branch of superior laryngeal. External laryngeal nerve is having only motor supply. It gives innervation to cricothyroid muscle. All the muscles of the larynx is innervated by recurrent laryngeal nerve, and recurrent laryngeal nerve is also giving innervation, sensory innervation to the lower part of laryngeal cavity. So this point is highly important for you. This point is highly important for you. Have you understood about the nerve supply? Everyone, have you understood about the nerve supply? That means upper part of larynx sensory innervation is via internal laryngeal nerve. Lower part of the laryngeal cavity below the vocal cords, it is having recurrent laryngeal nerve innervation. All the muscles of the larynx is supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external laryngeal nerve. Yes, you are right, Venkatesh. Now vascular supply. Superior laryngeal artery, branch of superior thyroid artery, and inferior laryngeal artery, branch of inferior thyroid artery is important for the vascular supply. So vascular supply of larynx is from two sources: superior laryngeal artery, inferior laryngeal artery. Superior laryngeal artery, branch of superior thyroid artery, inferior laryngeal artery, branch of inferior thyroid artery. Venous drainage. So veins will drain into inferior laryngeal vein, superior laryngeal into internal jugular vein, and inferior laryngeal will ultimately drain into left brachiocephalic. So that means inferior thyroid, so that means superior laryngeal vein and inferior laryngeal vein drain it, and they will drain into internal jugular vein. Clinical correlation, I would like to talk about cricothyrotomy. Cricothyrotomy, ma'am. Vrishwali, yes, 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 dear. Yes, dear. Yes, definitely, dear. I will take it. Okay. I will take it that also. Yes, dear. I will take it. Cricothyroidotomy is an emergency procedure to make a temporary airway. Actually, sometimes what happens, there is failed in intubation, and in that case, we can go for thyroidotomy. And exactly, if I talk about cricothyroidotomy, it's a procedure of emergency procedure to form a temporary airway passage. So there is a less time and we want to save the patient. So it's typically in a situation of any kind of obstruction. If there is any kind of obstruction in the, for example, the obstruction is by foreign body, the obstruction is for angioedema, the obstruction is for facial trauma, and intubation has become unsuccessful and there is very less time to save the patient, then we can go with the procedure of cricothyroidotomy, emergency situation to save the life of the person. No, it can be done. It can be done more easily than intubation. So cricothyroidectomy is a technique. It is less time, dear, less time. Venkatesh, less time. It is a procedure in which there is a actually there is incision made to cricothyroid ligament. So exactly, it is an incision done for cricothyroid ligament, and if the patient is not able to breathe properly and we want to save the patient, so and intubation is not successful because of any kind of much large swellings, angioedema and all, then we can go for this cricothyroid dectomy procedure. An incision is made in cricothyroid ligament. A small incision is made in the midline, as you can see here. The cricothyroid ligament, and incision is made in this case so that we can save the person. Now I would also like to talk I will also like to talk about the vocal cord paralysis. So if I talk about vocal cord paralysis, the important vocal cord paralysis and the injury of recurrent laryngeal nerve is an important case. So exactly, I just want that you should know the approximate important condition where there can be the recurrent laryngeal nerve injury, and this can cause to vocal cord paralysis. Okay. So exactly, so exactly, you can see the case of apical. If there is a case of apical cancer, so exactly, if we talk about, so exactly, if I talk about the important procedures. Okay, so yes, if we talk about the important cases, so exactly the reasons will be apical lung cancer, thyroid cancer, aortic aneurysm, cervical lymphadenopathy. So these are the conditions. Okay, so exactly, yes, Venkatesh, teacher's palsy, actually 30 minutes and more. Yeah, the whole entire process will be taking 30-40 minutes and all, but exactly it is a safe procedure. Okay, it is a safe procedure, and if in emergency condition, if the patient is just close to the hospital, and all the procedures in the case of emergency should be done as fast as all, because from starting to the end point, yes, it is approximately 25-30 to 40 minutes range is there. Okay. So if we use for a case of needle cricothyroidectomy, I think it's 40 minutes approximately, but you should refer with a anesthesia doctor. I will like that. I will not be a better person to give you this answer. You should refer to the anesthesia faculty. Okay. Now, these are certain conditions where there can be affection or injury to the recurrent laryngeal nerve, or the inferior thyroid artery is taken out, is ligated. So, exactly this is a respiration process. It is quite the vocal cords are apart and there is a sufficient air passages there. This is with the phonation. This is unilateral palsy and this is the bilateral palsy. So, in case of bilateral recurrent laryngeal nerve paralysis, you can say it's in adducted position and there is no space for the airway passage. So, in unilateral case of recurrent laryngeal nerve injury, vocal cord is paralyzed, but again the other side vocal cord is abducted. So, certain airway passage is maintained and the patient will have hoarseness of voice. The patient will have hoarseness of voice, but in case of bilateral paralysis, what happens? There is no abduction and the vocal cord will be in adducted position, paramedian position. So, I just want this is the right vocal cord normal, this is the left vocal cord paralyzed, this is the right vocal cord normal and the left is, so you can see slight space is there because the other side vocal cord is not paralyzed, and you can see still there will be slight hoarseness of voice, but it is not so serious condition as this is the case of paralyzed right and the vocal. So you can see exactly very less space is there and there is no airway passage and it's a emergency condition. If you want to save the patient, you have to go with the cricothyroidectomy or procedure as early as possible. So in the situation where the nerves are partially paralyzed, the vocal cord become paralyzed in full adducted position. If it is occurs bilaterally, the rima glottis, as you can see, is in completely closed position and the process to restore the airway passage can be done only surgical. So, surgical procedure has to be done to restore the airway passage. So, I just want to show you this. So, here you can see vocal cord is in abducted, vocal cord is in abducted position. Here the vocal cord is in abducted position. So, very less airway passage is maintained between the rima glottis, and ultimately to save the patient, surgical interventions has to be done. So if you want to save the patient, you have to go with surgical interventions. Okay. So yes, I will actually want you to know this, that my procedures and all, my timetables and all, I will come with the next sessions also. I will tell you the timetable. I just want you to give the details of the, so let me just check how is the order of the sessions being taken. The next will be abdomen and pelvis. So abdomen and pelvis, then we will have the thorax, then we will have the lower limb, and then we will have the upper limb. So this will be the sequence that most of the part is covered up, important parts. Exactly, if we can go topic wise, one or important topic, this is very conceptual, you can just write in the messages of the and I will come up with the explanation of that topics only. So I hope I was able to complete many of the aspects and just go through this. It will be highly beneficial for you. All the best and keep studying.